সাউন্ড শোনা যাচ্ছে না। হ্যালো, স্টার্ট হয়েছে কি?
We are waiting for everybody to join. Hello.
Hello, am I audible?
Yes, you are audible.
Yes, you are audible.
Thank you very much. Thank you.
We are live on YouTube and we are having a very smooth stream. So when do we start? Let us know, please.
Dr. Jena will start 7:05. He already told.
So that is the first
7:05 to
presentation.
maximum 10. So in the meantime, I think we should. Yes, because it is and he's very in a bad schedule.
So should we start?
Yes, well, I think we can start.
Okay, just give me 1 minute, please. Good evening, everybody. Welcome to this special episode of World Sickle Cell Day 2021, which is organized by the Hemoglobinopathies and Hemophilia Control Unit, HHCU Department of Pathology, North Bengal Medical College and Hospital, Sushrutanagar, Darjeeling, West Bengal, in association with Nilam Path Lectures. At the outme request, Professor Dr. Bidut Krishna Goswami, sir, please introduce and start the session. Sir, please start.
So thank you, Dr. Nadim. Good evening, everyone. I hope all of you and your loved ones are safe and sound in this COVID pandemic. It has impacted our daily normal lives massively, but amidst all these hardship, normal activities, and today we are getting one program that is a very important one. Before starting of this program, I must express my gratitude to our esteemed patrons, Professor Rudranarayan Bhattacharya, Chairman RKS, Professor Indrajit Shah, Principal NBMCH, Professor Sanjay Mallik, MSVP NBMCH, and Dr. Shandip Sengupta, Dean of Students Affairs NBMCH. Today, the 19th June, we have gathered here on this platform to celebrate World Sickle Cell Day. And unlike thalassemia, the awareness surrounding sickle cell disease is quite low and requires thorough attention not only among the masses but also among some healthcare workers as well, including doctors. Sickle cell, the world's first discovered inherited blood disorder, is highly prevalent in different parts of the world, and India. This disease is mostly found among the tribal population in pockets of Maharashtra, Madhya Pradesh, Odisha and South India, and its adjoining states as well. Scenario in West Bengal is a little bit different thanks to state government with its program of Thalassemia Control Unit, now known as HHCU, that is Hemoglobinopathy and Hemophilia Control Unit, in all of the state-owned hospital and medical colleges, which has made us fortunate to carry out screening procedures for over a decade with yield of knowledge about the several other hemoglobinopathies, including sickle cell disease, in numerous pockets of North Bengal as well. So this is one wonderful opportunity for us to obtain knowledge from our learned speaker, as I welcome Professor Ravindra Kumar Jena, Professor and Head BMT Physician, Department of Clinical Hematology, Professor Rajiv De, Consultant Hematologist, Dr. Shoikat Datto, Consultant Hematologist, Professor Madhumita Nandi, Professor and Head HOD Medicine, Pediatric Medicine NBMC, Dr. Taposh Kumar Ghosh, Associate Professor, Professor Shoikat Datto, Professor in Kuch Bihar Medical College, Dr. Bishwajit Haldar, Associate Professor, Department of Pathology, North Bengal Medical College, Dr. Kalyan Khan, Associate Professor, Department of Pathology, North Bengal Medical College, Dr. Indrolil Chakraborty, Associate Professor, Department of Pathology. I also welcome all the eminent dignitaries and participants on and offline in this seminar webinar dedicated to World Sickle Cell Day. So let us start. Thank you.
Thank you so much, Dr. Goswami, for that elaborate, extensive, and such a wonderful introduction. The first topic is by Dr. Jena, and should we wait for him? Because he hasn't logged in yet.
I think he was talking that by 7:05 he will start. He's ready to start. I think his lecture is to be shared.
No, I can't see him in the group. If he has to first log in. I'll share his lecture, provided of course he logs in.
Just let me have it.
He has to log in to the Google Meet, only then I can share the lecture for him.
Yes. Let me have it.
Hello? Professor Goswami?
Hello. Yes. Bishwajit, you want to?
Am I audible?
Yes, you are audible, Dr. Biswajit. Go ahead.
Sir?
Yes, you are audible.
Am I audible?
Yes, go ahead. Please speak. Your microphone is muted. Please unmute your microphone, please, Dr. Biswajit.
Okay.
Yeah, it's getting muted again. Please unmute it, please.
Yes.
Please unmute your microphone, please.
Now we are waiting actually a little bit more because I think Dr. Nadim will introduce you.
Dr.
I think
Biswajit,
Dr.
yeah, I'm waiting for Dr. Jana to join in.
Yes. I have rang him. I think he's trying. I think so. He just rang me a few minutes back.
Okay.
Thank you, Rajiv. Thanks to all audience dignitaries. Thank you so much.
Hello. Am I audible?
Sorry. We are waiting for Dr. Jana to join in, only then we can go ahead with the rest of it. Talk.
If we start the second session, then I think problem will be there.
Jena probably is involved with another program.
Can I start, sir? Hello, sir.
Sir?
Yes, please
Sorry.
tell me.
He himself called me that I am not able to share. You please arrange.
No, his presentation is ready to be shared, but he has to join in the Google Meet before we can share. I can share the presentation, but that's not a problem. The only thing is he has to join the Google Meet. So I'm waiting for him to join the Google Meet.
I know that's the problem. This is the problem of that online system. So I think we can now start with, in that case, we can start with Rajiv. I think so.
Is it okay if I start with Dr. Rajiv's presentation?
Because, otherwise, no, Vishwajit, as because you are dedicated for Jena, Dr. Jena. Please, we are all waiting eagerly, all are waiting. Please. Yeah.
Dr. Goswami, can I start?
No.
Please wait.
You hold the phone. He took few minutes time. Should we wait for few minutes?
No problem, let's wait.
Because he is the pretty senior and okay, what is Rajiv? What is your opinion, Dr. De?
Yeah, we can wait for a few minutes.
Few minutes. I think he was talking. Just I am joining.
He is involved in a separate meeting, I think.
Yes. I think he will join within few minutes.
Doesn't matter. Just let's wait for a minute or so. He will join. No issues. Once he joins, then I will share Dr. Biswajit's answers.
So have you talked to him?
Yeah, I have.
Okay.
তুমিও কথা বলতে পারো?
না সে কি বললো কি জয়েন করছে?
হ্যাঁ বললেন আমাকে জাস্ট ফিউ মিনিটস দিন আমি এক্ষুনি জয়েন করছি। তো তুমি এখন চাইলে জয়েন করতে পারো। তুমি কথা বলতে পারো একটু তোমার সাথে।
if okay fine.
I think he should be we are saying Pranav Da, Shubhendu Bikash, probably Dr. Tapun Ghosh, Dr. Taposh Ghosh, thank you.
Thank you, sir.
Mahodari.
Thank you, sir.
Mahodari has joined.
Madam's microphone is in mute mode, I think.
Yeah, please keep your microphones on the mute mode as of now. Let's wait for Dr. Jana to joins in and we start in the system and fall in line. Dr. Jana is joining. Yeah, he's joined. Welcome, Dr. Jana. So I take this pleasure to introduce the moderator for the first talk, which is Dr. Biswajit Haldar. He is an MD, Associate Professor in the Department of Pathology, North Bengal Medical College, a life member of IMA, ISC and IPM, conducted both UG and PG examination as internal and external examiner. He has guided many MD pathology students over years with multiple publications in national and international journals, organized various state and local CMEs and conferences. I would request Dr. Biswajit Haldar, sir, please introduce Dr. Jana, and from there we will start.
Please, Dr. Biswajit, you start.
Please introduce Dr. Jana and we will start from there.
Biswajit, please introduce Dr. Jana. Dr. Biswajit.
Yeah.
Dr. Bishwajit.
So, am I audible, Dr. Biswajit?
আবার চলে গেল কোথায়?
Dr. Rajiv, am I audible?
Yes, sir.
Yes, audible.
চলে এসছে
Yeah.
স্যার।
Dr. Vidyut Goswami, I introduce Dr. Jena.
হ্যাঁ।
Dr. Jena needs no introduction.
চলে গেছিস তো। বল।
Yeah, Dr. Vidyut Goswami, I think you can introduce Dr. Jena, as Dr. Jena needs no introduction before this audience. So, you can introduce. Because we are already late for 15 minutes.
Okay, sir. Yes, rightly you are not in need of introduction to anyone. You are world famous. Okay. So let us, Dr. Ravindra Kumar Jena.
Yeah.
He is past president Indian Society of Indian Hematology and Blood Transfusion, secretary Eastern Hematology Group, secretary Odisha Hematology Group, member of editorial board of Indian Journal of Hematology and International Hemoglobin. He is DM PhD Hematology examiners of West Bengal University, MCI inspector for hematology discipline, member of a Journal of Hematology and Blood Transfusion, member of ASH and other professional bodies about hematology and oncology over India. He has received training of BMT at University of Minnesota and advanced training on thalassemia from Cyprus. More than 70 publications in international and national journal. He is presently professor and head of the department, BMT physician in SJ Hospital, Cuttack. Thank you, Dr. Jana. Please start your program.
So, I think I am audible. Still I am
Yes,
audible.
yes,
Okay,
yes.
that was-
Yes, sir,
because
you are very much audible.
So why I am checking, because there was a technical problem which I couldn't speak well on my earlier. Anyway, at the outset, my congratulations and thank you very much to Professor Goswami for giving me this opportunity. So why this noise is coming? Okay.
Please,
So
your microphone.
So in 20 minutes I'll be finishing very briefly how do I manage sickle cell disease in 2021. Next please. Slide please. Next slide please. So make it a larger screen. It is a yes.
Yeah, please.
So this is the distribution of sickle cell disease in that green color. On the left side you find across the globe. It is confined to the African countries, then comes Middle East, then Indian, then Southeast regions and so on. This is the distribution. On the right side column you have the India. You have so many states. The overall prevalence of sickle cell varies even from region to region in the same state. Usually the common states who are affected by the sickle cell is Odisha, Chhattisgarh, Madhya Pradesh and Maharashtra, Tamil Nadu and north side of the Bengal and Delhi. But this is our perception, but I believe because of the population migration and many movement of so many people across the country, so there is no bar or immunity that every state will be or any state is immune or there is no sickle cell disease. And I am sure in the next few years this sickle cell is going to be present across our country. Next please. So these are the common complications of adult sickle cell disease. It starts from the brain where you have so many complications on the cerebrovascular disease. It can affect heart in the form of so many cardiological complications, lung, liver, bone is avascular necrosis, bone and various bone complications is also another leading cause of complication, morbidity of sickle cell disease. And under you find the skin condition. So these are the sickle nephropathy. So these are the common complications which occurs in a form of morbidity so far sickle cell is concerned. Next please. So clinical features, it is a hemolytic anemia. It's a chronic hemolytic anemia. All features will be there usually from childhood. since birth with a family history, you find other family members also may have that feature. They are prone for infections. Acute complications include vaso-occlusive crisis like hand-foot syndrome, painful crisis, brain damage, aplastic crisis, sequestration crisis can be splenic or hepatic. Then the chronic organ damage, as you know, there can be subclinical obstructions which can lead to leg ulcer, gallstone, bone complications and damage to every organ of the body. It can affect the heart, it can lung, it can eye, it can nervous system, so on. So chronic hemolytic anemia since childhood with family history, infections, acute complications, chronic organs. Next please. Yeah, this is important. In this one slide, I will tell what is the management strategy of sickle cell disease. If you look at the extreme right side, the pain history, the acute pain, and if a sickle cell patient comes, we have to how to strategical, how to form a strategy for management. The pain history is very important, which can be acute pain in the vaso-occlusive crisis and chronic pain that has to be taken care and that has to be managed. On the middle, you find the medical history and investigations. These are addressed to the evaluating for any organ damage. You should always evaluate the kidney function by your kidney test or urine examination, the cardiac status by echocardiography, as to know the liver status. Then you have to periodically screen the bones to know the orthopedic complications. Of course, the nervous system on eyes and visual and the sleep pattern also. These are the various organs which are affected commonly and various investigations which you should look for to know or evaluate the ongoing status of the particular organ. On all this evaluation, this is the organ evaluation. On the extreme left side, you have a detailed comorbidities can be sickle related and non-sickle related. Sickle related, as I have told you, can have renal complications, cardiovascular, neurological, priapism, leg ulcer, and history of DVT thrombosis. So, if already complications are there, you have to search for these complications, accordingly manage. And another important factor is called your non-sickle morbidity, because so the diabetes and hypertension, as you know, these are the chronic morbidity condition. If these are present in a setting of sickle cell diabetes, the organ damage and all the complications. So comorbidities like diabetes and hypertension should be managed aggressively with achieving the ideal target so that the further organ damage cannot be precipitated by the sickle cell disease. So in this way, the whole strategy for managing the sickle cell disease, if a patient comes to you, you have to look for the pain history, you have to look for the various organ evaluation, the possibility of any organ evaluation, then you have to look for comorbidities. If any organ has been already affected and how to manage ideally, then look for diabetes and hypertension and manage them very aggressively. So these are the strategy for management of sickle cell disease. Next please. So the standard treatment I will enumerate is known to everybody: hydroxyurea, folic acid, methylcobalamin. You have to avoid dehydration, extreme climatic conditions, because that can precipitate vaso-occlusive crisis. Infection, they are prone for infection, should go for infection prophylaxis. Monitor for cholestasis and organ damage at least once in a year, and you maintain hemoglobin around 7 to 10. So the upper limit 10. Never try to raise the hemoglobin more than 10, because it will increase the viscosity that will lead to vaso-occlusive crisis. So this is the standard management on the stable patient. Next please. If there is a vaso-occlusive crisis, the management it is a very excruciating painful, it's a very painful condition. So aggressively control the pain with whatever possible most potent analgesic. You have to maintain adequate hydration, infection control, and saturation more than 95%, prevent acidosis, observe for complication, and manage accordingly. So these are the basic principles of managing a vaso-occlusive crisis. Next please. So if the vaso-occlusive crisis not managed by your standard management, then here your aggressive or your approach will be here. The hemoglobin S, you have to reduce the hemoglobin S in between 30 to 50%, and simultaneously you have to maintain hemoglobin around 10 also. So without raising the hemoglobin beyond 10, if you can reduce the hemoglobin S level to a level of 30 to 50%, then you are going to reduce the vaso-occlusive crisis to a great extent possible. Either you can go for the red cell apheresis followed by normal red cell transfusion, that is the most effective way of reducing the hemoglobin S level. If the apheresis is not available, if the therapeutic apheresis facilities are not available, you can go for simple exchange transfusion. Means remove 1 unit of blood, administer the normal unit of the blood. In this way, you can reduce the hemoglobin S level also. And of course, other routine treatment you have to continue. This is the principle of management of a resistant vaso-occlusive crisis. I am sure my colleagues who are involved in the management, they face similar type of complications in some patients. Next, please. So the simple expense transfer, we have a study of a benefit of simple crisis not responding to standard therapy. Next, please. So we have a 4 patients and where who didn't go for red cell apheresis. Just by around 2 to 3 simple transfusion, we could reduce the vaso-occlusive crisis, resistant vaso-occlusive crisis, not responding to the standard therapy at a median time of 2 days. And here the important point is that though the guideline or though the earlier thought was that you have to reduce the hemoglobin S less than 50% to manage the resistant vaso-occlusive crisis, but that's not the true, because if in many patients, in our 4 patients, even by a reduction of 4 to 5% of hemoglobin S, also very effective in controlling the resistant vaso-occlusive crisis. That's the new information which you have, which could find out in this 4 patients. So simple exchange transfusion, even 1 or 2 units of blood also, it helps to control the resistant vaso-occlusive crisis. Next, please. So real case history, I'll go through very quickly few case histories, how their real cases, how the things are managed at our end. So next, please. So case number 1 is a female child, 2 years old, 15 kg. It's a 10 months of, is a 2 years old and complained that there was a pain or the hand-foot syndrome, swelling of the hand and foot since 10 months of age. There was splenomegaly, anemia, hemoglobin S 84.6, F 12.1, other parameters within normal limits. So the diagnosis is a sickle cell disease homozygous with a hand-foot syndrome. Next, please. So here the management is a symptomatic manage, folic acid, penicillin prophylaxis, vaccination you have to go for pneumococcal influenza and hepatitis B routinely in all pediatric patients. It was in 2002. There was always a question mark. I was a voracious user of hydroxyurea, even if there was no data, there was no document, there was no US FDA approval, because there was no other treatment left. There was a question mark at that time whether you should go for hydroxyurea or not, though I was using in practice rampantly. Any pediatric patients comes with this type of complications, I put them hydroxyurea. You break the capsule, the dose have to be, because there is only one strength 500 milligram, no liquid preparation, no lesser strength. Even I have to break the capsule. Accordingly, we can guess what you can give the actual dose of that hydroxyurea in a form of powder. So next, please. Here comes one other landmark study, that was Baby Hawk study. They treated the hydroxyurea with both symptomatic and asymptomatic patients. They found that the total painful events and the dactylitis, hand-foot syndrome, acute chest syndrome, and the incident of hospitalization was quite significantly reduced if you use hydroxyurea in this infant means up to 2 years of age in comparison to the placebo group. Can I have next slide? So interesting, can I have next slide? Next, please. Interesting, look, this is a subset analysis with the asymptomatic patient. In pediatric patients up to 2 years old child without any symptoms, hydroxyurea was given. In comparison with the placebo group, they found that the incidence of the further dactylitis, hospitalization, transfusion requirement is significantly reduced in comparison to the placebo group. Next, please. So from that study, from that landmark Baby Hawk track, hydroxyurea gets approved in children in 2017, irrespective of symptoms. So all patients of the sickle cell disease, if it's a pediatric patient, irrespective of symptom, hydroxyurea should be given because it benefits. Number 2, a female, 23 years, 45 kg, chartered accountant by profession. She was a case of sickle cell homozygous. Her presentation was recurrent vaso-occlusive crisis. Other pictures were normal limit. Investigations were within normal limits. Next, please. So young female with sickle cell vaso-occlusive crisis, and so the diagnosis was homozygous. Management was the routine folic acid, methylcobalamin injections, hydroxyurea. We put it at the 10 milligram per kg body weight, roughly 500, other supportive therapy. Next, please. Even if we have put on the hydroxyurea at the low dose, the pain still continuing. We escalated dose of the hydroxyurea to 20 milligram. We went up to 1 gram per day. And even after that also there was still frequent pain, no other complication. Even if after increasing the dose to 20 milligram per kg per day, there was still presence of the frequent vaso-occlusive crisis. Again, further improve the hydroxyurea. We went up to maximum tolerated dose, that is up to 30 to 35 milligram per kg per day. And then calcium was added and other treatment was as before also. Next please. In spite of going for the maximum tolerated dose, or still there is a dull-lacking pain. The hemoglobin F was still sitting on 25.6. S was reduced from 72.3 to 57.2, but there was still pain was continuing because of the MRI of the spine and hip. There was edema, infection of the right ilium. So there was a dull-lacking pain was persistent in spite of escalating the dose of hydroxyurea to the maximum tolerated dose. Then L-glutamine at that time in the 19 it was US FDA approved, came to the market. We used the L-glutamine, the sachet of the 15 gram twice daily orally. Next please. So after that asymptomatic, no pain, comfortable parameters were normal limit. Now she is expressed a desire to marry her colleagues, counseling done and the marriage is almost fixed. After hopefully the COVID-19 improves, she is going to marry her colleagues, also is another chartered accountant. So next please. So that is another landmark study which came in the New England Journal Medicine 2019. L-glutamine was used. For the interest of time, I won't go to details. That was a benefit has been established. So now the current status of L-glutamine is that it should be added to hydroxyurea if there is a suboptimal response or intolerance or unacceptable to the side effects. So this is the current status of L-glutamine in a setting at present. So now the next is that is how to optimize the hydroxyurea dose. You have a two concept: fixed dose, you can use 10 to 20 milligram per kg per dose, versus maximum tolerated dose which can go up to 30 to 35 milligram per kg, where the target of absolute neutrophil count you have to maintain around 1. In between 1500 to 3000. Of course the reticulocyte count should be with 100 to 200 thousand per square meter body surface. That is how the target of achieving the maximum tolerated dose. Next please. So these are the three prospective study, Indian studies. One is by D.K. Patel Burla, second by Deepti Jain from Gujarat, third is from my institute. What is the prospective? Both in we have used a fixed low dose, 10 milligram per kg of body weight. We found that the incidence of the vaso-occlusive crisis, blood transfusion, hospitalization are significantly reduced. Even 90% of the patients, they can be asymptomatic by this low fixed dose of hydroxyurea. And giving a low and fixed dose of hydroxyurea, it has a lot of benefit. The cytopenia is extremely uncommon. The very vigorous monitoring is very not required. If a patient from the very remote area, they can take the medicine, even they can come after 3 months, 4 months, 6 months also. Even if the cytopenia occurs in a very small percent of cases, once you stop, it's reversible without any complications. So today, that's unanimously all the Indian studies have found that. So the low dose means we should start always with 10 milligram per kg per day. If in also respond, in 10% of cases, those who do not respond, you may escalate the hydroxyurea depending on the need. Next please. This is our study, low dose of beneficial effect of low fixed dose of hydroxyurea, which you have prepared. I won't go to details of the study because of the interest of time. Next please. So another concept is iron overload chelation. It is also discussed because it is. Next please. We have another prospective study. We have taken vaso-occlusive crisis, roughly 240 prospective study, 5 years, the 208% of sickle cell homozygous. Next please. We have, what I have seen that iron overload more than 1000 nanogram per ml, it only occurs in 9.6% cases, means roughly 10% cases. Below contrary, you find 10% cases can have low iron status also, where the anemia may be disproportionate, where you may need to go for iron supplement also. So iron overload to an amount requires in only 10% of cases. Next please, in our Indian haplotype. So iron chelation is required in 10% cases, contrary to the high percentage Senegal, Bantu or in African population. Next please. Another is a perinatal outcome in sickle cell. You know, a pregnancy is another entity. Can I have next please? So quickly I will give a summary of our Next, please. So this is the first prospective study of outcome of the pregnancy in sickle cell disease in our Palm Institute. What we have seen that, look at these two red color. The first one is maternal mortality. It is a high risk pregnancy. It has a lot of complications of babies and of mother. It should be done in an institution. Look at the maternal mortality. It can be 0% also. If you do the delivery in an institution where all facilities are available, you can have a maternal mortality of 0%. And look at the live birth. In 84.4% cases, you can have a still live child, a successful pregnancy with a 0 mortality. So that's the message. So it is, though it's a high risk message, should be taken up with the institutions where all facilities are available. You can have a successful pregnancy in 84.4% with 0% of the mortality. Next, please. So pregnancy is safe, acceptable, but is a high risk, should be taken up in an institution with all facilities. Next, please. So then this is the combined. Next, please. On the left side is a old lady, about 60 or 70 years old lady, 65 female, have 5 children. Went to a surgeon because he found a lump in the left abdomen, and when the X-ray was done, there was a calcified spleen. And look at the bone complication. The classic of the bone complication of the vertebral spine. The surgeon was a smart, intelligent. She suspected something wrong. She sent to evaluated and found to have a sickle cell homozygous. Imagine sickle cell homozygous being diagnosed at the age of 65 years old age with having 5 children. Pregnancy is also high risk, lot of complications. She was completely asymptomatic. Next, please. On the other side, this is a sickle cell family. These are two. I think I cannot show you that. On the extreme right side is the father. On the towards its right is the elder son as a sickle cell homozygous engineering student, died suddenly with acute chest syndrome. Even if she was receiving treatment under my care with all sincerity and all dedications. I doubted probably this is a high risk, there is a problem is there. So the behind the right side, after one child, younger brother, engineering student, I escalated the hydroxyurea dose up to 35 milligram per kg. Still, so my fear was came true one day after 4 months. She again succumbed because of the acute chest syndrome also. So here is a family, even if with the best treatment, whatever the available treatment, even if with the maximum toilet dose, they have a sudden death because of the acute chest syndrome. Next, please. So risk prediction is really unpredictable in our haplotype. We don't have any marker to tell who are the patients who can behave in that way. So risk prediction is unpredictable. Next, please. So US FDA approval of the sickle cell disease new drugs, hydroxyurea for children, L-glutamine, crizanlizumab, and voxelotor. These are the new drugs which have been approved to be used in sickle cell disease. Next, please. So how to go? Suppose you have done so many things. So in 2021, if a patient of vaso-occlusive crisis come, the management has to be done as per the standard protocol I have already enumerated. You have to prevent what you go for by doing the lifestyle modification, address the precipitating factors, infections, dehydration, acidosis, exertions. You have to prevent that. You have to go for vaccination. Hydroxyurea should be used. L-glutamine is approved in 2017. Voxelotor is approved in 2019, and crizanlizumab of course is approved in 2019. So these are the new approved drugs, but we do not have any markers or any guideline or any evidence-based your recommendation how to after hydroxyurea, beyond hydroxyurea, how these new drugs L-glutamine, voxelotor, crizanlizumab in the sequential use or combination use or rationality or evidence-based recommendation lacking. And yes, please, I think we require more exactly pinpoint of the new drugs, what is the current position, how to use in the best possible and rational way. To conclude, ladies and gentlemen, sickle cell disease in India is mild to moderate severity. Next, please. Vaso-occlusive crisis is the commonest cause of morbidity and mortality. Next. Should be managed by experienced team. Next. So go on. So hydroxyurea to all the patients, irrespective of the symptoms. Red cell transfusion should be utilized as per the specified indication with extra care because it has a lot of adverse drug reaction. Next, please. Iron chelation is not required in 90% cases, maybe required in 10% cases. Pregnancy is a high risk, is successful in 84% of cases. L-glutamine, voxelotor, and crizanlizumab are the new immediately, if you want.
Yes, Dr. Vishwajit Vallar has already joined, so I will ask him to speak. You unmute.
Thank you, Professor Ravindra Kumar Jena, for a very good presentation. And now I am asking an audience if anybody having any question regarding this sickle cell disease management, please ask him.
Yeah, Dr. Jena.
Please from the audience
Yes,
have any
yes.
question for sickle cell disease.
Yes, Dr. Rajiv, please.
Yeah. So, thank you for an excellent presentation, for an overview of sickle cell management in the short 20 minutes time. One thing is very interesting, that is, I appreciate your study on low-dose hydroxyurea as well as other people like Diptigen. The standard line of therapy recommended by to give hydroxyurea to maximum tolerated dose. So start at a low dose and irrespective of the response, just go on till you have a mild bone marrow suppression, like which you showed, 500 to 1000. And the problem of this maximum tolerated dose is, in lower socioeconomic countries like India, it is expensive. Hydroxyurea is still can't be afforded by all the people, especially those who suffer from sickle cell disease. And it is really that if patient develops severe cytopenia, it is very difficult to reach proper health institute. So now I want your opinion. Do you stick to this low-dose hydroxyurea irrespective of the disease manifestation, or you just if in first few months it doesn't respond properly, then you escalate to maximum tolerated dose? So what do you recommend for Indian people? Low dose 10 milligram or to maximum tolerated dose?
Look, so a lot of noise is coming. Yeah. Okay. Then now okay. Look, so before coming to my recommendation or my suggestion, let me give you the logic why there is a difference in the dose. The presentation, the clinical severity varies wildly from different haplotypes. You have 5 haplotypes: Senegal, Bantu, and Cameroon, and African haplotypes, and you have Arab Indian haplotypes. If you look at the clinical presentation of the sickle cell disease, is a spectrum. On one end, you have a vaso-occlusive and phenotype. On the other, if you look at the African haplotype, that Senegal, Bantu, and Cameroon, they are predominating of hemolytic haplotype. Where the hemolysis is much more predominant. If you look at Arab Indian haplotype, the vaso-occlusive crisis is very, very predominant phenotype. However, in between also, you have a various combination of vaso-occlusion and hemolysis. So Arab Indian haplotypes, they behave completely differently in the comparison to their counterpart. Now come to the second point. So there is a lot of clinical variation, complications of the different our patients in comparison to the other patients. Third, the international studies which have been occurred in the America, particularly in US, they are only and others. That is why their recommendation does not fit all, or does not much of our Arab Indian haplotype. Now come to the Indian child. We have done 3 prospective studies. One is Bimsar, Burla, another from SCB, third is from Diptigen. There is another study also. They are all prospective. There is a unanimous 90% success rate with a low fixed dose. So that means, so if any patient comes to me, irrespective of the symptom, I put them on 10 milligram per kg per day. Wait for see for 3 months. If it does not improve, in 10% cases, you have to increase the dose to a 20 milligram. Then if you still not increase, you can go up to MTD. Honestly telling, suppose out of my 10,000 patients, I must be giving only 5% only to MTD to an extent of 30 to 35. 90% patients, they are happy, they are absolutely symptom free with a 10 milligram per kg per day. And it has a lot of advantage, I told you. Not only the finance, but only the handling the monitoring the cytopenia also. So to be effective, you need not go for cytopenia.
Thank you.
Professor Jena, I am Professor Pranab Bhattacharya. What is the role of
E-selectin in the treatment of the vaso-occlusive crisis, and what is your experience on that?
Look, so this pre-selectin inhibitors on crizanlizumab, it's a very coming up with a lot of noises has been created. But what the original study which has been done, it has a lot of limitations also. It has a lot of limitations. It has a lot of drawbacks also. I think though it is effective in controlling the vaso-occlusive crisis, but its exact position vis-a-vis with hydroxyurea has not been delineated. So we require more. Who are the patients who will be requiring the crizanlizumab? Maybe if you are using hydroxyurea and you have escalated to maximum tolerated dose, or if there is an intolerance to the hydroxyurea, consider this pre-selectin inhibitor. But other than today, the first line of therapy is the hydroxyurea.
Right.
Dr. Jena, I am Dr. Shaikhat Datto, Professor of Medicine of MGN Medical College in Coach Bihar. I would like to ask you one thing. In Orissa, we find that we know that Orissa is an endemic zone for malaria, and also we are finally finding that Orissa is having plenty of sickle cell cases. So, do you have any study from your center to depict the role of malaria? Which that means whether malaria vivax or Plasmodium falciparum in relation to the sickle cell patients?
Okay, look, we do have our study. I think you can log into our Indian Journal of Hematology. We have a single center experience. We have a 25,000 sample screen, and we found roughly few thousand patients of sickle cell. There are certain new revelations I will be telling. Though sickle cell is considered to be a tribal population, it's not true at present. You find across the Odisha state, even many of the coastal belt also, it is also now rampantly present, number one. So sickle cell disease is not only confined to tribal population. And the second important information which came from our study is that it was confined to lower caste, middle caste, type or a particular community. This is not the true at present because of the intercaste marriage and population migration. It is across the caste. It occurs every higher caste, including Brahmin and Khandayat, Karan, and every higher caste of every state also. And third is, so the lower economy, again it is believed that probably the low economy groups are much more affected, but no economy is a bar for that. So now sickle cell disease is across the state, across the economy status, across the caste, etc. And coming to its relation to malaria, it has been the epidemiologist, historian, they have hence peculiarly the distribution of sickle cell and malaria.
Sir, go ahead. We can hear you. Please go ahead.
With a lot of noise.
The noise is because everybody has put their microphone on. Please put your microphone off.
Okay.
Dr. Biswajit Haldar, please put your microphone off.
Yeah,
okay.
Only when you ask your questions, please only then put your microphone off. The speaker cannot speak.
Now it is better. Now it is better. Oh my God. Now it is real.
Sir, Professor Jena, sir, we have not sufficient time. We have to conclude the session now, sir.
Okay.
Please, sir, we have to complete the session now because
okay. So let me complete.
Yes, sir. Yes.
So far the malaria relationship is concerned, though the malaria and sickle cell disease, they are co-inherited or they are present in the same area. It was thought probably God has designed the malaria to just combine the sickle cell because malaria red cell or this give or that was sickle cell environment. The that sickle red cell is a very adverse environment for the growth and proliferation of malaria parasite. They trait, but the measures are also prone. But the malaria parasites are very smart. There is a lot of mutation. So having a sickle cell trait which will immune to the malaria severe infection, it does not hold true at present. Sickle cell can affect even sickle cell, the malaria patient also. Or malaria can affect sickle cell patient.
Thank you.
Thank you, Professor Jena, for a beautiful lecture, beautiful delivery and lucid presentation. And in conclusion, I must say there is some development in sickle cell management disease. As all of you know, from 1910, it was first described in sickle cell disease by James Herrick. But nowadays, from till 1980, there's no some management for sickle cell disease. From 1980 onwards, there is some management. First hydroxyurea come, then the bone marrow transplantation. Nowadays, there are so many drugs, even genetic transformation can be done. So, thank you very much, Professor Jena, for giving newer advancement in the treatment of sickle cell disease. Thank you, Professor Jena. Thank you all. Thank you very much.
Thank you so much. Thank you, Professor Jena, for your excellent deliberation.
Right. We go to the next topic, and the next topic is approach towards the sickle cell disease control program. To moderate that session, let me invite Dr. Kalyan Khan, who is an MD, MBA, Health Care Service Management. He's an Associate Professor, Pathology, Coordinator, Medical Education Unit, and Member Secretary, Institutional Ethics Committee of Reviewer of several national and international journals. Field of interest includes histopathology, laboratory quality management, hemoglobinopathies, medical education, bioethics, and hospital management. He is the organizing secretary of the International Conference on Heavy Metal Poisoning, which was done as LEDCON in 2018, actively involved in COVID-19 pandemic. Requesting Dr. Kalyan Khan to introduce Dr. Rajiv De, and from there we'll take over.
Good evening, everyone, and pranam. Thank you, Dr. Nadeem, for introducing me so nicely. Now, what I feel sincerely is that it's an honor for me, Dr. Rajiv De, in this program on behalf of the organizing committee. And as we all know, Dr. Rajiv De, he is a consultant hematologist, clinical hematology. He is a DM in clinical hematology, consultant hematologist and hemato-oncologist. He is the clinical lead bone marrow transplant program of Narayana Super Speciality Hospital, associate professor of the Department of Hematology in NRS Medical College. His approach, he is going to present to an approach towards a sickle cell disease program, control program, and case-based approaches to sickle cell disease, real life scenario. Now, as I know him personally, he's an expert in his field, definitely, and a really nice person at heart and a beautiful human being. So, on this auspicious World Sickle Cell Day 2021, I would like to welcome Dr. Rajiv De to start your discussion and welcome you on behalf of the organizing committee of this program. And start your discussion on the approach towards the sickle cell disease control program. Please, Dr. De.
Thank you, dear Chairperson, Dr. Kalyan Khan, for your kind introduction. I also thank Professor Bindut Goswami and our Nadeem sir and this academic group for giving me chance to speak on the topic. The topic, permission to share my presentation from my end. Okay.
Yes, please go ahead. I'll help you out.
Yeah.
Just press present now on the right side of your screen. On the lower right side, you will see there's a thing called present now. Just press that. Press your entire screen. There's a button called entire screen.
Present now, then
the whole entire screen. Then you will see a pop-up which will come in the center. Just press in the pop-up and press share.
Okay. So
I'll guide you. Yeah, your presentation is visible. Please make it full screen.
Okay.
Please make it full screen from the bottom. Yeah. Just make it full screen.
Yeah.
It's not yet full screen. It's not yet full screen. Please.
Is it?
No, it's not yet full.
My side. Full screen now?
No. Yeah, come again. Yeah, please.
Can I play? Acha, Rajiv, you just click on the read option, means just on the side of this PowerPoint presentation option, just on the left of that, you have a read option. You click on that and it will be full screen.
Anyway, start from the beginning, start present now. Your
Yes.
entire screen, and yeah, share your screen, yeah.
Go to enter screen and click on the, the other one, just beside it.
This one, reading view.
Yes, this one. Yes, reading view.
Okay.
Yeah, thank you, it's done.
Thank you for solving this.
Just requesting everybody,
Thank you for solving this.
just requesting everybody to please keep your mind on a background noise which is affecting the speaker. Please, thank you so much. Please go ahead.
Yeah, thank you. So my topic is approach towards a sickle cell disease control program. The problem is there is no standard national sickle cell disease control program. So let's discuss what is the utility of this program and how we can initiate such a program here or in future. Dr. Jena has about the epidemiology, and we know that sickle cell disease or hemoglobinopathy are restricted to some parts of the world. When we utter sickle cell disease, we think that it is restricted to Sub-Saharan Africa, but India is the second most common area or country of having maximum number of sickle cell disease. This is the average population percentage of sickle cell trait. Definitely in African population, the trait is high, around 1:5. And as far as hemoglobinopathy is concerned, in Asian population, it is 1:30. In India, the percentage of hemoglobinopathy is around 3 to 4%. But definitely in sickle cell disease, they are restricted to some states like central Indian states. So this is the first hemoglobinopathy, nationwide hemoglobinopathy screening program to assess the disease burden. And this is definitely a study with a lot of limitations because the study was restricted to 6 cities in India. It was started back in 2005, and it showed that, and Kolkata was one of them, it showed that there was around 0.77% of sickle cell trait in that study population and 0.06% of sickle homozygous. But definitely this study was not representative of the population because it was an institution-based, school-based study, not a population-based study. And depending on different hemoglobinopathy control program in different state, now we have a rough idea of sickle cell carrier status, that is around 1 to 40% depending on the different state, different zone. So the epidemiology is different in different populations. Now, the sickle cell disease prevalent states are mainly the central and western Madhya Pradesh, Odisha, Chhattisgarh, Maharashtra, Gujarat. But West Bengal is not also far behind considering its huge population. So especially the North Bengal districts, we know the epidemiological information from Dr. Vidyut Goswami's study, and so North Bengal districts has a reasonable amount of sickle cell disease trait. And in India, we're surprised to know that around 2 lakh babies are born with hemoglobinopathies and mainly with sickle cell diseases. The pathophysiology we know, so I'm going to describe in detail. So there is a mutation in beta globin gene at position 6, glutamic acid replaced by valine. And what is caused? It causes the sickling if there is hypoxic condition. So it was a simple pathophysiology a few years back, but now what we understood that sickle cell disease is basically an inflammatory condition because it is an inflammatory condition and which affects the endothelial cells and produces endotheliopathy. And the main complications are because of this inflammatory state and the endotheliopathy, which causes loss of vasculopathy like vaso-occlusion, the most common cause of death, and even the silent stroke, leg ulcers, and chronic pain, and then neurogenic pain. So all these things can happen. So there is an important component of hemolysis because we know the sickle cell can pass through the spleen and they break down and they cause anemia. But following anemia, following release of hemoglobin in the circulation, which quenches the nitric oxide, it causes vaso-occlusion, causes stimulation of not only the RBCs. So now sickle cell disease is not considered only the RBC disorder. It involves all the cellular components of blood like WBCs as well and platelets. So in those conditions where there is high number of WBCs, leukocytosis, the complications are more, and there is a role of hydroxyurea in reducing those now. So anyways, so vasculopathy causes vaso-occlusion, and there is another important component of inflammatory state which causes ischemia reperfusion injury, and some new drugs are in the horizon and they are available in the market also, which blocks these inflammatory conditions of the sickle cell disorders. So ultimately, it causes a chronic organ damage, vaso-occlusive crisis, acute chest syndrome, and ultimately cause a different chronic manifestations. So starting from CNS to periphery, bones, all the organs are affected by different complications in sickle cell disease. So it is an global health disorders. Different manifestations occurs at different ages. So in the childhood, acute chest syndrome, vaso-occlusive crisis, infections, these are the most common complications. But in the middle-aged, pulmonary hypertension, polylithiasis, leg ulcers, vaso-occlusive crisis, these are there. And in the older age group, usually the chronic organ damage becomes the most important complications and most disturbing complications. So depending on the age, as sickle cell, because initially sickle cell disorder patients wouldn't survive more than beyond their adolescence, but in thanks to the better management, better treatment, so they are living long. And as they are living long, now we know that any sickle cell control program should not only focus the children's or pediatric population, but also have a program encompassing all age groups. So the hemoglobinopathies will constitute an increase in global health burden that was predicted in 2011 by Dr. Weatherall, and who is the father of hemoglobinopathy. Because these hemoglobinopathies are mainly confined to the so-called poor socio-economic countries, lower economic countries, where there is an increased rate of consanguineous marriages, and with a poor health care system, with a less developed, the people need to pay out of their pocket for the treatment. So all because of all these things, the hemoglobinopathies, he predicted 10 years back that hemoglobinopathies will constitute an increasing global health burden, and that we know. But it is a globally neglected disease because of this thing also. Everything is determined by the politics and economy. So as it is mainly affecting the relatively developing countries and underdeveloped countries, so it is a neglected disease. But the burden is huge. So if you look into this Indian data, we can see that around 2 lakh patients are with sickle cell disease are taking birth in every year. This is the incidence. The prevalence is nearly, and the death rate per year is around 3,000 to 5,000. So, and there are some unanswered questions how these patients and specifically the trait individuals can be identified, how there can be a holistic control program, how the economic problem will be solved. So as it mainly involves the developing countries, the issues needs to be addressed are, there are low income countries where the facilities for even simple screening and are still not available. And there are lack of centers where an holistic treatment for this disorder is available. There are some ethics regarding counseling, consanguineous marriages, prenatal diagnosis, abortions. So these are there, and definitely it is involved with high cost. And 20%, this is a few data that how severe it is. 20% of children dies of sickle cell disease before they reach their age of 2, and 30% of children die before reaching adulthood. And 60 to 70% school children with sickle cell disease are unable to complete their 10 standard. So the problem is huge. And it has also has got a significant financial burden also to the individual, to the family, as well as to the government. There are direct and indirect health costs are involved. Direct costs involve the primary care visit, emergency care visit, hospitalization, blood transfusion, bone marrow transplantation, treatment, medicines. And indirect costs involve the current loss of productivity, future productivity loss, these things. So there is an assessment of economic say that as per as the National Health Mission data, every hemoglobinopathy, thalassemia or sickle cell patients needs around 2 lakh rupees each year for each year of survival. And how much indirectly it costs? 3,500 crores are lost because of loss of economy per year because of parents missing their work, and loss of future GDP because these patients taken some steps for sickle cell disease control as a part of National Hemoglobinopathy and Hemophilia Control Program. The program is in place since 2018 and we are also part of that program. Different studies from different states, Tamil Nadu, Odisha, Gujarat, has said that it is associated with lot of morbidity and mortality. 48% cases there is sudden death. 24% has acute chest syndrome, and in studies Gujarat. But the most common cause of death is vaso-occlusive crisis, which involves 72% of all death followed by the infection. So these are the data. In West Bengal also, the different districts has got different rates of this hemoglobinopathy as well as sickle cell disorders. Mainly it is prevalent in the North Bengal districts as well as Midnapur and Purulia. And this is a study from North Bengal by Dr. Vidyut Goswami, and it showed that there is, in some populations, there is increased rate of sickle cell disorders, like this tribal population, Santals. In Nepali populations also there is significant proportion of sickle cell trait. VOC, Dr. Jena has already mentioned that VOC is a significant cause of morbidity and mortality, but this is only the tip of iceberg. Sickle cell disease has got a lot of other complications and which causes the life of the sickle cell patients, caregiver, as well as government is RMP. Chronic disease involves all the organs, and so the approach towards a sickle cell control program should be a multiple approach should be there. It is not a clinician based or a hematologist based approach. So all the stakeholders should be involved in managing sickle cell disease patients. So the key stakeholders are medical experts, doctors, hematologists, pediatrician, healthcare administrators, and as well as industry, because they can make different drugs available, and really has a significant role in management of sickle cell, which is available as a generic drug with a very low price. And we don't need to go for these high-end drugs before going for hydroxyurea. These are different sickle cell disease control program in different states, that is Gujarat, Odisha, Maharashtra, and Chhattisgarh. So the way we have a thalassemia control program way back since 2009. So in these states there are sickle cell control, and after the initiation of National Health Mission, this hemoglobinopathy and hemophilia control program, like thalassemia control program, state thalassemia control program, this sickle cell control program also incorporated under this National Hemoglobinopathy and Hemophilia Control Program. Now, the patients with sickle cell disease approaches to healthcare system in different ways in rural and urban population. In the urban population, usually when they develop a symptom, they directly can go to district hospitals or tertiary care center, and so they can get definitive therapy immediately. And some urban areas also has got prenatal screening program, and different private centers also do some prenatal screening programs. But it is very difficult for rural population. They need to go through a separate hierarchical healthcare system to reach to a proper center where they can get a proper treatment. So while designing a control program, we need to keep this thing in mind so that these both urban and rural population can be addressed for a better management. Yeah, the control program should be comprehensive. It should contain the component of education and public awareness, very important, where different NGOs, different public advocacy system can play a very important role. Then access to comprehensive healthcare and therapeutic management, and which is a healthcare institute based, where the holistic sickle cell treatment strategy should be in place. We know that we have 24 thalassemia control unit TCUs, and 10 TCUs are coming up. And so every district now we have a TCUs. So utilizing the infrastructure of TCUs, we can provide the comprehensive sickle cell management. And then the next important is research and longitudinal data. Research doesn't mean that we need to do a very high-end research in laboratory. So we can do some epidemiological study to know what is the gravity of the situation. We don't know basically how many sickle cell patients are there in West Bengal, in my district, in my area, and how many of them are actually approaching to institute, how many of them are having other applications. The problem is because there is no standard program, the sickle cell disease patients goes to different departments. They goes to medicine, they go to nephrology department if they present with hematuria and acute renal failure. Many of them go to orthopedics department because of severe bone pain, and they may go to pulmonologist also. So it's just scattered. And then vocational rehabilitation and the emerging need needs to be addressed when these are in place. The most important component in sickle cell control program is newborn screening program. There is an advantage of sickle cell disease compared to thalassemia is that in thalassemia the new program is not very efficacious because of this hemoglobin F component, because they disappear, they start to come down after 6 months of age, and by 1 year age they actually disappear. So to confidently diagnose them by simple tests like HPLC, we need to wait till 1 year. But it is not in sickle cell disease. In sickle cell disease, in newborn patients, we can do either the HPLC or the sickling test or the simple solubility test, and by which we can detect the sickle cell diseases. So the newborn screening program must be, a strong newborn screening program must be in place as a part of the sickle cell control program. Some states also does this thing, and like this neonatal screening of sickle cell anemia, this is done in Odisha, and they showed that around 0.2 to 0.8% population has new birth has got sickle cell disease, and they differ in different populations. Although, as Dr. Jena said, that because of this intercaste marriage, this dogma is not very effective nowadays. And this states has got this sickle cell control program in place. And the vision of the National Health Mission is that mainly the carrying out the awareness, education and screening program in the community and schools, establish an laboratory for career detection program and screening program for all hemoglobinopathies including sickle cell, as well as a newborn screening program. Important is screening pregnant women. The ideal should be, the strategy of till now, the strategy of hemoglobinopathy control program is a population-based, school-based control program. But I don't think this is very much effective, because if we want to actually reduce the birth of sickle cell child or birth of thalasssemic child, then the we need to find out the population at risk. The population at risk is antenatal mother. So we need to have a very strict screening program for antenatal mother with a target of 100 antenatal mother is found to be carrier of sickle cell or thalassemia. Then the husband's sample needs to be checked and the prenatal diagnosis must be in place. The study, we often say about the different control program of hemoglobinopathy, thalassemia. We give examples of Italy, Cyprus, Iran. But if we go through their strategy, it is clearly said that the reduction of the thalassemic child, reduction of the sickle cell child was possible because of the effective prenatal diagnosis program, not because of the community-based screening program. So, but now, except these two institutes, NRS Medical College and Calcutta Medical College, no other government hospital has got a prenatal diagnosis facilities. So it must be in place if we want to actually reduce the birth of sickle cell disease. And adequate therapy should be provided to all the important state health departments. It should provide the adequate blood transfusion. There should be universal accessibility to hydroxyurea support because it is till now really a magic drug for sickle cell disease. And there should be provision of high-end curative treatment like bone marrow transplants in the institutes of excellence. So it should involve all the stakeholders and facilities which I already explained. Laboratory services should be in place. I think Dr. Bindut Goswami will focus on it. Screening approach should be based on school, adolescents, mass screening. All these things can be there. But for sickle cell, the newborn screening program should really be very much stringent and robust. And for thalassemia, screening program must be very stringent. And there should be an ideal way of referral system there's a very important role of NGOs who can develop awareness of these disease and they can sensitize the population for screening. And there should be this is three-step approach. One is the government should recognize that and the health community that sickle cell disease is a priority. Because we shouldn't have that fool's heaven that sickle cell is not our problem. It is a problem of Africa. So it is our problem. And so we need to recognize that. We need to strengthen the implementation at national and state level, which has started, but still long way to go. And we need to adapt the innovative technologies and processes for diagnosis as well as treatment. So, these are the different strategy and objectives taken by National Health Mission, to which I already mentioned basically. This is an article from ASH publication. There are the different responsibilities for different caregivers. General practitioner, first contact center and expertise center. So there should be a hierarchical way and by which we can actually categorize, and this is the hierarchical system of developing countries, that is community level early diagnosis, immunization, management of fever, malaria, sensitization awareness. Primary health care center, we should give the treatment for the complications of sickle cell disease, and the expertise center, we should provide the curative treatment as well as the research one. Yeah. For the sickle cell control program, the important part is healthcare, training, research, as well as advocacy. All these four systems should be in place, they are complementary to each other. And research should play a very important place, in the management of sickle cell control. Research should include not only the biomedical research, but also population health research, as well as social and behavioral research to address the issues for proper rehabilitation. And because this huge number of patients, we don't want these humans to be lost or wasted. And they can very well be placed to increase the GDP of our country. So there are some myths about this sickle cell disease. That is, the myth is sickle cell and thalassemia are basically black issues. Actually not, they can involve all genetic populations. Meat is well, so can't be a carrier. It is not that we know. So there should be a dedicated carrier screening program in place. Everybody can be affected. You can catch the condition. Fact is, you only get them by inheriting them. So proper prenatal diagnosis, proper antenatal counseling, proper premarital counseling is required. Screening is for women only? Absolutely not. It is men and women, and people with conditions will die young. But we now know that they can live like a normal person, and so they can have a later long-standing complications. So we need to address those things. So thank you. With basically scribbling of this sickle cell control program, I think in near future this well-formed sickle cell control program will be in place under National Health Mission. Thank you.
Thank you so much, Dr. De. And it was such a beautiful presentation with starting with the basis of this control program and comprehensively dealing with all aspects of it. And personally, and is that today is also National Public Health Dentistry Day. Today is World Sickle Cell Day, but at the same time, today is the National Public Health Dentistry Day. And because of this COVID-19 pandemic, we are seeing that public health is basically taking a front seat. And this also means control programs and sickle cell. It is also definitely a public health problem as of now. Now, may I ask a simple question that because of you are also the mentor of our this hemoglobinopathy and the hemophilia control unit of the North Bengal chapter, Government of West Bengal. Now, may I ask, sir, 19 situation, its footprint says that not only the acute emergencies, even chronic diseases are going to suffer because of the healthcare system being too much involved with management of this COVID-19 scenario, pandemic scenario. So, do you feel we need to have some preparedness regarding this this sickle cell disease control program in view of this pandemic situation? Are we going to modify ourselves or have some preparedness if this pandemic is going to say linger longer?
Yeah, very practical question. The thing is, the sickle cell control program should go hand in hand with thalassemia control program. And for thalassemia control program, because we see more of thalassemia patients in my area, really they are suffering. They are suffering because they are not able only to come to hospital for regular blood transfusion and regular medications, iron chelation. And I have some experience of sickle cell patients from Alipurduar. She landed up in Alipurduar Medical District Hospital with a vaso-occlusive crisis. The symptoms suggest a vaso-occlusive crisis. And there was no treatment available, and the patient was referred to North Bengal Medical College. But because of this pandemic situation, lack of transport, they reached very late, and ultimately the patient succumbed at North Bengal Medical College. So definitely we don't have data, but we can apprehend that many of these hemoglobinopathy patients are suffering from COVID-19 situation. But whether they are, this disorder a risk factor for COVID infections or not, that we don't know. The study is not there. But all of them who falls under government guideline, they should be vaccinated. So that I can say. All the patients who are more than 18 years of age, they should be a important group. So on a priority basis, they need to be vaccinated.
And at the same time, we are doing here vaccination programs for those who, as of now, as below 18 years, they are not getting the vaccine. So at least the caregivers, caregivers of those patients who are below 18 years of age, they should be vaccinated as a separate program. So thank you so much. If anybody has any other questions, we are running late. So fast question, anybody?
I think we are running late. Yes.
Yeah, we are running very late, very late. Yes, sir. Yes, sir.
Rajiv, usually I don't usually ask you a question, but my splenectomy has got any role in the treatment of this to prevent the vaso-occlusive crisis? Splenectomy.
Splenectomy. If I give this answer in a single line, that is, splenectomy doesn't have any role for preventing vaso-occlusive crisis, and only because sickle cell disease, and that's why we need to give proper vaccination, pneumococcal vaccination, influenza vaccination, meningococcal and hemophilia influenza vaccination in sickle cells, because there is autosplenectomy here. But splenectomy doesn't have any role.
Dr. Bidyut Goswami, Professor Bidyut Goswami was, sir, you are possibly asking something. Professor Bidyut Goswami, sir.
I think we'll go to the next topic.
Okay, so thank you so much. Thank you, Dr. Day.
Thank you, Dr. Kal, moderating this program. Wonderfully done. We go to the next part of it, something which interests us most, we the selfish pathologists. So which is lab diagnosis of sickle cell disease. So before I ask the speaker to speak, let me introduce.
Nothing to ask. First of all, I must thank Dr. Dev for Dr. Dev. Thank you very much for your. Thank you very much for your.
There is some problem with
There's a net problem. Anyway, we'll go ahead.
Connectivity issues, I think.
Yeah, we will go ahead with it. Now the next topic
please.
is on the lab diagnosis of sickle cell disease. And to moderate that session, let me invite Dr. Indranil Chakravarti. Dr. Indranil Chakravarti is an MD Pathology, DHM, MA, MS, affiliated from Nilam Medical College in the year 2003 with distinction and honors. Did his MD in Pathology. And he is an ISE Fellow from the AIMS New Delhi, a Diploma in Hospital Management. He is presently posted as an Associate Professor of Pathology at the North Bengal Medical College, West Bengal. He is a very famous invited speaker in various conferences with multiple national and international publications. Presently, he is the Secretary of the West Bengal Cytology Chapter. Let me request Dr. Indranil, please take over and introduce the speaker.
Thank you so much, Nadim sir. Good evening, everybody. Today on the World Sickle Cell Day 2021, I sincerely thank Professor Goswami, Dr. Nadim, and all the speakers and delegates for coming together and sharing their knowledge and experience about this very important but neglected genetic disease, particularly when India bears the second highest burden of sickle cell. Now, I've been noticing that many of our audience, some of our undergraduate students have also logged in, as well as those from the nursing college. So just to remind them that the sickle cell disease, this encompasses not only the homozygous state, that is the sickle cell anemia, but also the heterozygous states where this hemoglobin S combined with hemoglobin C, hemoglobin D, and particularly in our part of West Bengal, that is in North Bengal, hemoglobin E, which is very prevalent. And detection of these cases are very important to control the spread of this disease. So to talk more about this, about the diagnosis of this sickle cell disease, it is my proud privilege to introduce Professor Bidyut Krishna Goswami, my teacher, and he has been the co-guide of my thesis on hematology as well. He needs no introduction. He is the head of the Department of Pathology, North Bengal Medical College, as well as the in charge of the Hemoglobinopathy and Hemophilia Control Unit, North Bengal Medical College. He is the technical director of the Regional Blood Transfusion Center of our college, as well as the director of the Central Clinical Laboratory. He has multiple publications, and his first love has always been hematology. and he has published several original articles on hematology and presented them in national and international conferences. He has been an avid organizer he had organized the IPM State Conference as the co-chairperson, the State Cytology Conference in 2017 and 2019 as the organizing chairperson, as well as various CMEs on hematology, and he has been the ex-president of the West Bengal Cytology Society. So may I request Professor Goswami to please take over.
Dr. Bidut Goswami, please share your screen. Just press present now, which is on the right lower side of your screen. Dr. Goswami I think he is to rejoin.
Is he presenting from laptop?
I have no clue on that. I think he has just gone off the meeting. I think he has to rejoin. Can you just call him on the phone?
Yeah.
Requesting everybody to keep their mic muted.
Yeah, he has joined.
Just press present now, which is on the right lower side of your screen. On the right lower side, there is a button called present now. Right side, right lower side. Present now,
Present now.
Present now and then entire screen you have to present.
Present now and then you press another button screen.
Entire screen, right?
Yeah.
Then you press in the center of your screen and press share.
Share.
First you have to press in the center of the screen, only then the share button will highlight.
Yeah. Right.
Yeah, that's it.
Yes.
Your screen is now visible. Now please share the PowerPoint from the taskbar, from the below taskbar. Just open your PowerPoint from the taskbar below. The bar on the lower side, horizontal bar. Just press on the PowerPoint. Yeah, just press double click there. Right, make it full screen, yeah. Perfect, fine. Please go ahead. Just press that on that hide button there right in front of you. That small hide button which is next to the stop.
Am I audible?
Yeah, perfectly audible, absolutely clear. Just go ahead. Please start.
Okay, thank you so much. So thank you, Dr. Nadim. Thank you, Indranil, and all other dignitaries staying on and offline. My respected colleagues and students, we have already one marvelous presentation from none other than Dr. Jaina, followed by our favorite Dr. Rajiv De, and after their marvelous presentation, I don't know on this very simple topic whether it will be impressive or not. Let me try. Be patient, please. So to start with, I must acknowledge the appropriate authority, HHCU. In fact, that was the point I wanted to raise in front of Rajiv, that when the concept was there, the thalassemia control unit, and that is converted to hemoglobinopathies control unit. That indicate that we are going towards also controlling S as well. Previously, we are getting more aware about all the hemoglobinopathies with the starting of that particular program. So we are very much indebted to that program. The RKS chairman, the principal, the MSB sir and Dean of Students Affairs, we are indebted to them. My colleagues and staff, Department of Pathology, North Bengal Medical College has helped me a lot for this presentation. My esteemed colleague and staff. and other departments. I'm also indebted to them. All counselor, lab tech, data entry operator and staff of HHCU North Bengal Medical College. They have done a marvelous job. And of course, the patients, volunteers and persons involved in this activity are no less important. We are from an area where hemoglobinopathies are observed even in non-anemic individuals. Yes, we have got one paper, pattern of hemoglobinopathy among non-anemic individuals from a rural tertiary care center. And we have found that, yes, good number of cases of hemoglobinopathies are seen even having normal hemoglobin level. And we are also living in observed that this is hemoglobin E, hemoglobin variant, but other variants, though rare, are also gradually being seen, especially hemoglobin S. So this is hemoglobin S, and it is taken from Google, and we can see that the distribution pattern of hemoglobin S at different concentration. And these information is very not now known that most common hemoglobin variant is structural abnormality, the isolated, replacement of glutamic acid by valine in 6th position, poor solubility, RBC, red cell show characteristics say that is sickle cell. There may be holylic appearance as well. There is polymerization, oxidant substance generation, adherence of the red cell to vascular endothelium, leading to so many other problems. This is one, this map I cannot like this map of India, but unfortunately it is found. What is the job? My job is today is like that, highlight lab diagnosis of sickle cell disease. It can present with a big spectrum, starting from S trait to sickle cell anemia with their manifestation, heterozygous state with thalassemias and other hemoglobinopathy. Also can be present with various complications of the disease process and also therapy related, including complications due to blood transfusion. So covering everything in this small session is not possible. So what I have done, I will focus on lab diagnosis of SCD presenting for the first time with presentation of some cases of illustration. Mutation study is very, very vital. Similarly, IFE and that globin chain electrophoresis is also very vital, but they will not be discussed over here. Yes, I am a little bit fascinated about historical presentation of any type of performance, any type of activity, historical, what is the little bit history. And this is, if I go through, this is related to some lab investigations. 1910, one young man, yes, story, named Walter Clement Noel from Island Grenada, a dental student studying in Chicago, Dr. James B. Herrick. This name has already been taken. With complaints of pain episodes, symptoms of anemia. Herrick was a cardiologist and he was not too interested to see Noel's case. So he referred it to Ernest Irons, his residence. Irons examined Noel's blood under microscope and saw red blood cells he described as having the shape of a sickle. When Herrick saw this in chart, he became interested. And because he saw that this might be a new unknown disease, he subsequently published a paper in one of the medical journal in which he used the term sickle cell disease. So I think the credit should go to Dr. Ernest Irons. Now there are a lot of other historical perspectives, like from very beginning, hereditary, familial, acute and chronic hemolytic anemia. They have used the term Negro, have used the term black people. Artificially produced meniscocytosis. At that time it was told as meniscocytosis because of its shape, drepanocytes and sickling. It is a great mimicker of several other problems. So lab diagnosis is very, very vital. to differentiate all these disease. And I'm getting another interesting finding, that is moist stasis method of detection of sickle cell, that is keeping pressure when in my body and then collect the blood and see under the microscope after making some sorts of that, putting some petroleum jelly, making some chamber. So little bit modification 1940. So we are getting a lot of papers from since 1922, 27, 43 and 1951 famous Nobel Prize winning chemist Dr. Linus Pauling and Harvey Itano. They discovered that this is something, this hemoglobin is something different, chemical structures in persons with SCD. 2010 was considered the 100th anniversary of the discovery of SCD, though it is also told that this is misnomer. So we will enter into our basic topic, how to diagnose a case of SCD. To start with, we should follow textbook teaching. So we should get answer few questions. Is there evidence? What is the type of hemolytic mechanisms and what is the precise diagnosis? Is a hereditary hemolytic anemia suspected in this last line? And there are many other lines. One thing is to be kept in mind that in practice, the procedure is to be considered, found that sometimes going through simple microscopy observation, if I get one good number of sickle cell, I can point towards the final diagnosis. So that experienced observer must be there, and naturally it will be very much helpful to get the final diagnosis. We may proceed for any of the other tests as well, to rule out some other causes of hemolytic anemia. Of increased hemolysis, and we know that there is commonly done tests like your hemoglobin estimation, reticulocyte count. Of course, from our routine methodology, that automated cell counter has given us a lot of thought process on reticulocyte count as well. Examination of stained blood film, I call it direct blood film for RBC morphology, immense helpful. In fact, as one microscopist of RBC morphology, I consider this just like your examination of clinical examination of one patient from A to Z, RBC morphology. I am very much fascinated on seeing all these RBC types. Test for increased unconjugated serum bilirubin, it is already very simple, and urinary immunoglobulin. There are some other tests like your haptoglobulin, hemopexin, urinary hemoglobin and hemosiderin. Now if I think that hereditary hemolytic anemia is suspected, then I will follow again that textbook teaching. So causes may be within the RBC membrane, like hereditary cause, hereditary spherocytosis or eleptocytosis, some tests are there. Causes in the cell sap or cytoplasm, which is composed of hemoglobin, and there may be some enzymes. We will concentrate on this hemoglobin, particularly on the globin chain problem. Maybe deficient synthesis of globin chain, that is thalassemia, maybe structurally defective globin chain, hemoglobinopathy. In fact, this is an old description. Nowadays, everything encompasses into the same one, but still till date, I used to follow this classification because this is more, I can clarify nicely. So, we will have one list of procedures for lab diagnosis of SCD. And naturally, we should follow a defined protocol, which should be devised to suit individual local needs. As for example, say one person is there, one lab is there getting one hemoglobin variant study. He cannot install one physiological examinations are important. Family history. Often we forget all these things. And I've got one practice that whenever I see any peripheral blood film, immediately I look into the surname of that particular patient. And probably Kullan and my junior colleague will remember that we have seen one autopsy histopathology slides. I found some sickling phenomena in the blood vessels, and then I called them, and ultimately I asked them the name of the patient, and it was found to be Lohar. As actually in the Lohar group, the sickle cell anemia is very common. So next one is the collection of blood and preparation of hemolysis. Often This is also neglected. Collection of blood. I have kept one slide for this collection of blood. Hemolysis preparation. In fact, nowadays, as because these automated machines they are doing by themselves, it is being done with their ready-made agent. But had experience, we used to do by ourselves manually. Very vital. Blood count and film examination of RBC morphology. I have already told, particularly with the advent of automated cell counter. In fact, I will say this has enriched our that RBC interpretation. Reticulocyte count already told. Search for RBC inclusions body by the same stain for hemoglobin H inclusions. Assay of nutritional status. Often I advise in my report for iron status, vitamin B12 as and when needed, and other relevant blood biochemistry. Control sample preparation. This is another task of one pathologist. He will mix some normal blood with a patient, the hemolysis of hemoglobin S trait, hemolysis of hemoglobin E trait, and cord blood for hemoglobin F. And thereby he will make one A, S, E, F. Mind it, in foreign country, E is not common, they use C, hemoglobin C. Celluloid acid electrophoresis, yes, once upon a time, I will come later on, this was the only methodology in our laboratory, and the particularly pH is 8.5, sometimes we used pH 6.0 with citrate agar. Automated HPLC, after introduction of automated HPLC, in fact, everything we are not using, but I think we should use side by side. Physicochemical methods, some tests are there depending on physicochemical methods like SICKLE test, hemoglobin S insolubility test, of which SICKLE test is very simple using 2% sodium metabite or dicyanide, and it is very simple one. Roll-up examination of bone marrow little bit normal for non needed, though sometimes patients used to come, but this will be needed only in some specific cases like in complications when patients are coming in with a plastic crisis, or we can also go through, get some ideas about the iron deposition. For advanced studies, is an isoelectric focusing, globin chain electrophoresis, and molecular techniques for mutation study we can do. Protocol by Barbara Bain that for clinical purpose an adequate presumptive identification may be done, like combination of at least two techniques of hemoglobin variant study, clinical correlation, ethnic origin of the subject, so mind it, ethnicity is so important, and interpretation of blood count and the peripheral blood film. We were hearing about screening test from my previous speaker, about neonatal screening, and they are using, we are also using in our country on a good 3 card, dried blood spots, but that collections of blood is very, very vital, because we are to set that from the cord, we should be very specific about the collection of that cord blood, of the fetal blood. And normally HPLC and IEF is being done. Electrophoresis is not usually done. Prenatal screening by amniocentesis and CVS, as already told by Dr. Dey, that in our state only 2 centers are there. I think North Bengal is one area. In fact, we tried very much. I can remember that one of my fellow colleague from gynecology, he attended, but unfortunately the program has lost. Adult screening including antenatal mother, previously for the under-resourced laboratory, Nestrop, DCA was there for thalassemia and hemoglobin E respectively. But nowadays, in fact, HPLC, as because in our state, virtually in every corner HPLC is there, so it has replaced. Sample collection, as I have already told, most conveniently is the venous blood, preferably with K2-EDTA, and the direct film. I am all the time emphasizing on the direct film. In children, we can use the skin prick blood from Hill. In neonates, we can use the cord blood, as I have already told. Skin prick sample can also be taken. Cord blood, that umbilical cord vessels, never press it, never squeeze it, try to put one syringe and take the specific blood from fetal blood. Skin prick samples from neonates can be taken into a heparinized capillary tube. Sample must not be inadvertently obtained after blood transfusion has given. This is another area till date why this day celebration observed, because at least they should even today we are getting a lot of cases that patient is transfused with blood and sample is being sent. So sample must not be sent. In fact, I had one derivation on anemia as well. This is to be made one rule of thumb that whenever you are dealing with a case of anemia, never give transfusion. First you make the work. This is very vital. Making of direct film again. So this is one protocol as I found in Barbara Bain's that book. This is an excellent one for prenatal neonatal screening. Now I just want to touch what we did previously, old practice, and you can see the CAM, that is cellulose acid membrane, and marvelous separation of different type of hemoglobins, and this is the instrument. That is your power pack, the tank, the trace buffer is also there, and at that time what we used to do, ask for family history, ethnicity, physical examination, CBC, study of RBC morphology, reticulocyte count, rule out iron deficiency in case of microcytic hypochromic anemia by iron assay. I prefer iron, TIPC and ferritin. Hopefully now the importance of only ferritin is to be proven that only ferritin sometimes may be misguiding. Study of hemoglobin variance by hemoglobin electrophoresis at pH 8.9 or agar gel at pH 6.0. Test for hemoglobin F by alkali denaturation method, probably most are good. If you not seen, hemoglobin S is okay, they may be able to see it. To refer to higher center when we are getting some problematic cases. This was our old approach, but scenario changed a lot after introduction of HPLC. Now C is HPLC, cation exchange HPLC, high performance liquid chromatogram, high pressure liquid chromatogram. Principle, I am not going into the details of principle. The important word is the time of elution, that is retention time. Depending upon the retention time, we can separate by running the normal control simultaneously. Lot of advantages are there. This is fully automated. Huge number of sample can be done. Only 7 minutes are needed. Very small sample needed. Accurate quantification. Those who have done the electrophoresis, they will be able to say yes, hemoglobin A2 quantification is very tough in hemoglobin electrophoresis. Provisional identification of larger proportion of variant hemoglobin. In fact, because of HPLC, now we are in position to know existence of several other hemoglobin in this zone, and it has obviated the need of doing test for separately test for hemoglobin F, quantification of hemoglobin A2, etc., etc. So advantages are plenty. Of course, not without disadvantage. The most important one is the matter of co-elution with A2, which is very problematic over here in this northern region, because we are having huge number of cases of hemoglobin E, which is co-eluting at the site of hemoglobin A2. In fact, some machine wala, they came and I told them that whenever you are thinking of hemoglobin A1C quantification, as because people of this North Bengal zone is having high number of hemoglobin E, so are not very much helpful for those patients in which there is either trait or homozygous hemoglobin E is there. So that is a big problem with this HPLC machine. And hemoglobin S patients will show mild rise in hemoglobin A2 will come later on in my case presentation. There may be some sorts of problem in relation to hemoglobin A1C quantification and vice versa. So this is about your HPLC. This is one animation. This is interesting. How there you will get solvents, the pumps, the mixture, injector, column, and there is detector, and ultimately through the computer we are getting that curve. So I have selected this animation intentionally to make HPLC little bit easy. This is the chromatogram and you can see the retention time, determine sample identity, and this is the area of height is proportional to the quantity of analyte. Hemoglobin S solubility test, I am just going through the touching the interpretation, false positive result and false negative result. This is mostly made for the PGTs. Yes, this is one information. Other sickling hemoglobins are also there. At least 9 hemoglobins are there. They have both the beta-6 glutamic acid valent mutations and additional single point mutations in beta globin chain. And they have positive solubility test, but different in electrophoretic and chromatographic property. Surprisingly, one hemoglobin S antilase is associated with even a greater propensity to sickling than conventional hemoglobin S. This is one chart I've got from Barbara Bain's hemoglobinopathy diagnosis. In fact, from this chart we used to take help while interpretation of chromatogram. This is very much helpful. This is another chart from Daisy Lewis Practical Hematology. Again, it is also edited by Barbara Bain, and this is also very much helpful. So, yes, we have got few observations. This is also already mentioned about the spectrum of hemoglobin variants, and you can see that this is a short size observation, but still there are a good number, at least 33 cases of sickle cell disease with predominance of sickle beta thalassemia. In fact, subsequently we came to know that this why the importance of routine parental screening is so much important, and that is clearly indicated in this study. Here we can see that hemoglobin S beta thalassemia is definitely important, but the most prevalent is the hemoglobin that is S straight, followed by hemoglobin S beta is 12%, and the S straight is 80%, and homozygous hemoglobin S is 6%, around 6%, and 85% nearly patients coming from the tribal area. And that particular pockets, we know the titles as well, like your Lohar, Gwala, Khalko, etc., etc. Chikbaraik, Baraik, Boro, like that. So, and the most prevalent presentation is in the second decade and the third decade. So, again, I am asking you to keep in mind that the most frequent hemoglobinopathy of this zone is hemoglobin E hemoglobinopathy, which is very common among the. So, let us start case presentation. Case 1, M. Lohar, a male 13 years, coming from towards Tea Garden Basti, complaining of weakness, breathlessness on exertion for few months. On examination, GC is poor, pallor plus, low lymphadenopathy, no sternal tenderness, gum within normal limits, no petechial rash, mild hepatomegaly. Advised CBC, RBC morphology, reticulocyte count, LFT, urine for REME, stool for OPC with occult blood test, X-ray test, PFU. Test results: hemoglobin nearly 10, RBC count normal limits, MCV just low norm reduced marginally, MCH significantly reduced, MCHC reduced, RDW increased, reticulocyte high normal, and you can see the RBC morphology. So there is mild to moderately microcytic hypochromic with moderate anisopoikilocytosis, presence of leptocytes, Seeger cells, fragmented RBC, others NAD. So, and now we one advice, and hemoglobin E is very, very prevalent over here. So, whenever I get one microcytic hypochromic anemia, I used to write down that serum iron study and study hemoglobin variants. Stool was done and it was identified, hook-on ova was identified, OBT positive, urine within normal limit otherwise, except presence of occult blood, just weakly positive with occasional RBCs. X-ray chest, bronchovascular marking prominent, indicating that some bronchitis may be there. Iron profile, when it was subsequently done, then it is found that iron is very low, 23, RNTIBC 256, so marked reduction in the percent saturation, ferritin only 5. So what is your diagnosis? Is it a case of IDA as a result of hookworm infestation? Now let us see. As because HPLC was also in the meantime performed, what is the result? One peak at S window. Hemoglobin A2 raised mildly, not uncommon. Hemoglobin A2 is 6.3, not uncommon in presence of hemoglobin S, and you can see that hemoglobin S window and hemoglobin F is within normal limits. So with this, as this is an old case, we did hemoglobin electrophoresis and we can see one band at S region. So what is the diagnosis? Now we can get the diagnosis that this is a case of hemoglobin S straight with IDA, that is iron deficiency anemia. Now, what is the importance? I will come later on. Subsequently, what is done? I followed, they referred to HHCU Department of Pathology, parental screening and sibling study done. Mother was sickle trait, father normal, one brother normal, one sister was identified as S trait. Patient and full family was counseled accordingly, and patient was treated accordingly. Why this case is important? Ethnicity is to be kept in back of mind. A very commonly done test may give big clue. Patient was having hematuria. Why there was hematuria? Okay, we can explain the oral blood test in stool due to hookworm, but why there was hematuria? Now after this identification of hemoglobin S, as because in the renal papilla there is hypoxemia and that induced sickling over there causing renal hematuria. So mild hematuria, not to be it should be given proper importance. Examination of peripheral blood film for cell morphology very important. A pathologist can guide for relevant investigations, told repeatedly. Usually hemoglobin A2 may be reduced in IDA, may be even raised in presence of hemoglobin S. And IDA is a very commonly occurring entity, maybe combined with some relatively uncommon hemoglobinopathy, which needs proper evaluation to lessen birth of more deceased baby. So this is about your first case. Now second case. R. Baraik, 9 years, from Ranichera Tea Garden, Basti, presented with occasional abdominal pain and joint pain. History of blood transfusion is present only 2 times, last one 9 months back, but detail not found. One of his brother died of similar disease as known from his mother. On examination, mild pallor, jaundice mild, no lymphadenopathy, no sternal tenderness, mild splenomegaly, and it was sent to HHCU for CBC and HPLC. CBC, hemoglobin reduced 7.2, HCG 22.6, RBC count reduced 2.27, MCV is 99.6, nearly 100, so raised. MCH 31.7, MCHC 31.9, RDW 23.7, WBC TLC on the higher side, neutrophil 77%, platelet low normal. PBF RBC population reduced with several severe poikilocytosis, mixed population of microcytic hypochromic, but good number of macrocytes, ovulocytes, fragmented RBC, polychromatic RBC, occasional presence of elongated slender leaf sepal RBC as well as classical sickle cell. Sickle test was done and with the sodium metabisulfite and found to be positive. Unconjugated hyperbilirubinemia was also there. Chromatogram, we can see that there is a peak at S window, 82.1%, hemoglobin A2 is 5.3. Hemoglobin F is 10.4, which is raised significantly. So subsequently family screening was done. Both parents are hemoglobin S straight, one sister is hemoglobin S straight. Why this is presented? Just because of its classical peripheral blood film, sickle test observation and sickle test as well. Hemoglobin SS, we are really sometimes becoming very much problem because they are having raised hemoglobin. Raised hemoglobin along with hemoglobin F along with raised A2 sometimes can point towards double heterozygosity with beta thalassemia trait. And in this case we also thought, but after parental screening it was nullified. But we also get some other cases as well, and we are really in problem. We have gone through lot of literatures. In fact, we have found one entity. I don't know, that will be possible only after that molecular study, that hemoglobin SF entity like that. So mutation study could have been more helpful for this patient. Case 3. A Khatun, female 23 years, came for antenatal screening. Blood was collected for CBC and HPLC. Test result, hemoglobin 9.57, HCD 29.9, RBC count low normal, MCV marginally low 79.8, MCH 25.6 is 32.8, RDW just raised. So peripheral blood cell, mild microcytic and hypochromic with anisocytosis with presence of occasional target cells and fragmented RBC. In fact, this is a very, very common presentation of hemoglobin E hemoglobinopathy over here. If it was a case of iron deficiency, some sorts of pencil cell, cigar cell, etc., little bit more, though in mild iron deficiency, it could have been like this picture. But those who are experienced from this northern region, northeastern region, they will see this presence of these target cells, etc., etc. So likely to be a case of hemoglobin E hemoglobinopathy. Now, in this patient, as it was advised, so we are getting the chromatogram. What is chromatogram? And you can see there is 2 peaks. So peak at S window 56.1% at A to E. Now it is to be considered as E 29.2%. Hemoglobin F is little bit raised, and this patient's sickle test was negative. Why negative? Maybe related to high hemoglobin F content. And we could do hemoglobin, if we could do hemoglobin electrophoresis for this patient, it would have been better, but it could not be done. Subsequently, what is done with HPLC family screening? Mother is E trait, father is S trait. Sibling study, one sister S trait, one brother S trait, one sister E trait, one brother was normal. So why I have present? Because in this northern part of West Bengal, hemoglobin E hemoglobinopathy is the prevalent and common and over this area. With the time, previously there was no development of double heterozygosity because of lack of logistic facility or lack of communications. Usually they marry within themselves. But with the time now there is a huge improvement in the logistics. They are coming from here to there, and they are also getting married naturally, more mixing among the different racial groups. So development of different various double heterozygosity state is we are observing. Though the double heterozygous state, but clinically asymptomatic. This is the beauty. Clinically asymptomatic. And naturally it emphasizes the need of mass screening. Why? Because if it goes unknown, this E, if there is E, they can marry one beta thalassemia trait in subsequent areas of his family, and ultimately leading to development of a baby of E beta thalassemia present with beta thalassemia major like features. So this is important. Now case 4. This is R Boro, M7 years, 7 বছরের একটা baby, type 2 T estate coming from Bagdogara, type 2 T estate, admitted in pediatric ward with pallor, breathlessness, weakness, yellowish discoloration. No history of transfusion till then. Patient was sent to HHCU for CBC and HPLC. On examination, GC was average, pallor was 2+. No lymphadenopathy, no organomegaly, others unremarkable. Test results, you can see that hemoglobin is significantly low, 7.1. Yes, patient is getting now, after registration in the thalassemia control unit or HHCU, is department and getting transfusion as well, though not so severe. HCD is 23.2, RBC count 3, MCV low 77.3, MCH 23 reduced, MCHC 30, RDW is significantly raised. And this is the blood picture. You can see that mildly microcytic and hypochromic to moderate to marked anisocoagulopathy with presence of occasional sickle cells, fragmented RBC, target cell, polychromatic RBC and teardrop cells. Even we can see some nucleated RBC. So chromatogram, let us see the chromatogram. So there is one peak as at S window 64.4%. Hemoglobin A2 is 5.7. So consecutive 4% we are seeing that hemoglobin A2 is raised mildly. Hemoglobin F 19.4. significantly raised, hemoglobin A is 11.1. So what is the diagnosis? From this observation, again hemoglobin S window 64, hemoglobin F 19.4. So we made one provisional diagnosis of hemoglobin S beta thalassemia following the ready recorded chart as we have found in our textbook from Barbara Bain as well as from Daisy Lewis. Ultimately, these patients' babies mutation study was outsourced and confirmed that the disease of S beta thalassemia, double heterozygous state. Babies sickle, but it is not possible for other cases. It could not be possible. Test is negative. Family screening, hemoglobin, mother is hemoglobin A straight, father is beta thal trait. No other issue. Counsel and being followed up in HHCU. Why I have presented this case? Because reporting of anemic baby from a center lacking molecular lab facility is always a challenge, especially in case of double heterozygous state of thalassemia, maybe alpha or beta. Yes, we are not discussing alpha thalassemia at all, but that doesn't mean. In fact, there are a lot of findings, particularly with hemoglobin E, that possibility of alpha thalassemia is there. Good number of alpha thalassemia is there, which we cannot prove lack of facility. So, double heterozygous state of thalassemia and hemoglobin S hemoglobinopathy needs one molecular lab facility. We have handful of cases. I have already told that hemoglobin S hemoglobinopathy with significant rise in hemoglobin F, but parental study revealed only hemoglobin S hemoglobinopathies. So we couldn't reach why there is so much hemoglobin F is raised. So this ends my case presentation. Now I am in the take-home message. Though incidence is not so high in this geographical area, but hemoglobin S hemoglobinopathies deserve a special importance. One holistic approach is with batteries of tests which are needed for workup. Availability of regional molecular lab is also essential. I will request my mentor to sanction one, to arrange or to do something so that we can get one regional molecular lab over here. Opening up of new insight into the disease process will also be possible. Thank you very much. Thank you so much.
Thank you, sir, for the comprehensive and lucid presentation and the nicely worked up cases. They were really very informative. And just let me see if we have any questions in the chat box.
Dr. Goswami,
there is one.
what is the diagnosis of your second case? What is the diagnosis of your second case? Second case. What is the diagnosis of your second case? I could not follow. Diagnosis of your second case. And another question is, do you...
Sickle cell trait.
This is homozygous case.
Homozygous. Okay. And the question is there any role of Coombs test to exclude other causes of hemolytic anemia? Because you are doing routine blood test, CBC, like for spherocytes, fragility test, osmotic fragility test. Do you prefer Coombs test as routine?
No, I have already mentioned this point that there are, when I given that chart that some tests are to be done, we may be in need to do many tests.
Okay.
Rule out other possibility as well. As because this was coming, this blood came from pediatric ward with advice please do the HPLC and CBC. That's all.
Okay.
So
as the blood is coming from pediatric ward,
because patient will never say that I am having hemoglobin S with me.
No, I want to mention here.
They are diagnosing it is hemoglobin S. They are thinking if the patient is suffering from hemoglobinopathies or like hemoglobin S or homozygous or trait. Pediatrician. When blood comes from, you must do Coombs test. What blood and
no, this is 7-year-old male and
7-year pediatrics group. pediatrics department. Newborn.
7 years, 7 years, 7 means
No,
pediatric.
newborn. It's not this case. Routine test. Routine test. When
That is a different story.
comes from pediatric department. I think you should do CB.
You mean to say neonate, you mean to say neonate.
Neonates, yes.
No, that is a different workup. For neonate baby, this is different workup. Workup is totally different. I am not entering to that one.
Okay.
That is not my subject.
I think Dr. Rajiv wants to say something, please. Go ahead.
No, I think the confusion with this case because of raise A2. Because if A2 is raised, then and F is high, then we usually consider about sickle beta rather than sickle
Yes, right.
As sir said that the parental screening was done and it was a sickle failed. So it was sickle homozygous. I think there lies the confusion. Number one. And number two is as a workup of hemoglobinopathy, we don't usually do osmotic fragility test because
But you mentioned that's why I am asking.
osmotic, because that is usually guided by the RBC indices. In osmotic, if we want to rule out the hereditary spherocytosis, usually there is reticulocytosis and MCV is usually a bit high compared to a low or normal MCV. So that can give a guidance. So, and sequentially, okay, we are suspecting a hemolytic anemia, it doesn't show anything, then we can do, but usually it comes later on, not at a time.
Actually, Dr. Raji mentioned that this rise in hemoglobin F with rise in hemoglobin A2, it is recommended that when you are getting that, go for is.
For doing those tests.
We are 45 minutes behind schedule.
Okay.
Yeah. So,
Dr. Goswami.
As your mentor to Rajiv, what molecular test you would like to have asked from Rajiv?
We can have that in the panel discussion. We have got very eminent speakers in the panel.
I already placed through this sickle cell day there for long that please set up one molecular lab over here.
Yes, Rajiv, this is a request from all of us. All of us. And till it's not available, we are relying heavily on the parental study.
No, we have
but we do need a molecular lab as soon as possible. So, Nadim sir, let us move to the next program.
Desperately waiting, sir.
Your presentation is very, very good. Excellent presentation, and your motto is excellent.
Okay. So let's proceed to the next panel discussion.
Right, we move on to the last and I think the most heated element of this entire show, which is the panel discussion, management of sickle cell disease, practical pearls. And I would request Dr. Saikat Datta. Dr. Saikat Datta is an MD, DM Clinical Hematology, specialty training in bone marrow transplant from the famous Tata Memorial Hospital, Mumbai. Presently, he is a consultant hematopathologist, hemato-oncologist at the bone marrow transplant physician at the Bansal Hospital, Bhopal. Dr. Saikat Datta, please take over and introduce the rest of the speakers. Thank you.
Good evening. We are quite late, and I will. How should I?
What, you want to share your screen?
How should I share my screen?
Just press present now on the right side, right bottom side. There's a button called present now. Just click on that. And then press your entire screen. A central screen will pop up. Just press on that and share. As Dr. Saikat is presenting, let me request all the other people, please keep your mic muted, please. If you can see your screen, sir, please make it full screen. cross button so that this all these pops up go away. And this hide button. Yeah, you're ready to start, please.
Yeah. First of all, I would thank Dr. Bidut Goswami, who is my teacher, for inviting me in this program and giving me a chance to moderate this session. We have three excellent speakers and orator with me. Professor Madhumita Nandi, who is professor in HOD, Department of Pediatrics, North Bengal Medical College. We have my namesake, Professor Saikat Datta, who is professor HOD, MJN Medical College, Bihar, and Dr. Tapush Ghosh, Associate Professor, Department of Orthopedics. So it will be an interface between orthopedics, medicine and pediatrics. I would also request Dr. Rajiv Dey to be part of this panel discussion. So this panel will have a hematologist also. It will be more interesting. Now, in this discussion, we will raise the question which we will face daily when managing sickle cell anemia patients. Now, sickle cell disease is a sinister disease which may present with normal MCV and normal hemoglobin, MS. So, this is a case of 4-year female who presented in ER with definite history of sickle cell disease. Parents said that she is a case of sickle cell disease with severe pain in long bone, back and abdomen for 1 day. So my question to Professor Madhumita Nandi, when such type of case present to you in your ER or OPD without a history, what is your differential diagnosis, or what are your differential diagnoses?
Ma'am, please unmute your mic, please. Please unmute your mic before you start speaking. Yeah.
Namaskar, good evening, and thank you, Dr. Sankar, and I owe gratitude to Dr. Bidut Goswami, who is involved in the Department of Pediatrics also in this noble endeavor. It's a very relevant topic, and as regards your question, a 4-year-old child who is not presenting for the first time in ER with painful limbs, a differential diagnosis, so there is a wide variable differential diagnosis from growing pains to even hematological malignancies. Of course, the growing pains will not be that severe, but we have to do a thorough clinical examination. We have to take a thorough history. As my previous speakers, experts have also said, that history including the ethnicity. So thorough history, the duration of that pain, the time of when that pain is the time of that pain, and also a thorough physical examination to exclude other commoner causes of pain, like those of infective causes like osteomyelitis or pyogenic arthritis, also hematological involvement of bones and joints in, and also things like inflammatory conditions like vasculitis, which could involve the joints and the bones, and also inflammatory conditions like JIA and all. So a thorough history and a physical examination could go a long way in coming to a diagnosis. And to be frank, let me tell you that we don't see, I don't know why, we don't see many cases of sickle cell. The 1 year I'm here in North Bengal Medical College, I have not seen many pediatric cases of sickle cell. Rather, other things which I told you now are commoner causes of limb pain or joint pain or pain, or a child presenting with pain in the ER. But it's that doesn't mean that we should not keep the painful episodes associated with things like sickle cell disease also in mind, especially when he or she is coming from ethnic background where this is a possibility. Dr. Datta, you unmute yourself. You are muted.
Yeah, so going to our next panelist, Dr. Datta, I will ask that the same kind of picture, if the history is given that patient is a sickle cell anemia patient with this kind of back pain, extremity pain, what other thing you can have your mind rather than a painful crisis? What other things may have associated or may have in a sickle patient? Professor Datta, am I audible?
Hello? Yeah.
Yeah.
Can you repeat your question?
If a patient with this kind of extremity and back pain with a given history of sickle cell disease present to you, is there any other possibility that it's not a painful crisis? It may be other thing than painful crisis. What are the other DDs?
Well, if an adult patient presents to us with similar conditions, then we have to think of, apart from sickle cell crisis, we have to think of other conditions like deep vein thrombosis. In chest pain, a severe chest pain may even occur in a case of acute myocardial infarction, or even a musculoskeletal area pain like costochondritis, or some connective tissue disorders like rheumatoid or thing like vasculitis. All these may present in adults also.
Yes, thank you. And to Dr. Tapas, my question is, how to differentiate from a sickle painful crisis from avascular necrosis or osteomyelitis clinically? Dr. Ghosh, am I audible? Dr. Ghosh, are you there?
Yeah. Am I audible?
Yeah. Please, tell us.
Now, clinically it is very difficult to differentiate between sickle cell painful crisis from osteomyelitis.
You're not audible, Professor.
Hello?
Some problem with connectivity, I think.
So right now? Hello?
Dr. Ghosh, are you with us?
I'm there. Am I audible?
You're barely audible. So we'll come to Dr. Ghosh later on. So moving to the next question, how this vaso-occlusive pain crisis is managed? My question to Dr. Datta.
You see, vaso-occlusive crisis, my experience with management, as Madam had already said, and we don't know why, but really the patients which we deal in North Bengal, over my last stay I'm staying here since around more than 10 years, but I rarely find any sickle cell anemia, sickle cell crisis cases. My experience with management of these crises is when I was opposed there, as you are aware, we got to say a lot of cases, and therein what we did was we used to give main supplementation was with the hydration. We used to hydrate the patient adequately, taking care of the fact that he or she is not overhydrated, and also we used to give tramadol as a as an analgesic, targeting analgesic, and I think that still holds today.
Okay. Now my question to Dr. Rajiv, how do you choose your analgesic, or in your practice what analgesic do you use? It's morphine or non-opioid, it's IV or oral?
See, in sickle cell crisis, first of all, if we do other things along with analgesics, like as Dr. Shekhar, hydration properly, proper oxygenation, and we shouldn't forget the possibility of an infection because it is very common. So often we add antibiotics and as well as the analgesic. Usually we prefer the opioid analgesics in this situation, and opioid analgesics, it may be tramadolol, it may be some patient this patient control analgesia. These are said in that ideally patient should be put on patient control analgesia, PCA, and is one of them. But the problem is in our population, this patient control analgesia is not very effective, and that system in patients IV and the.
Now my question to Dr. Madhumita is that do you need IV hydration for every patient, or we can manage with oral hydration?
That depends on the that decision will vary from patient to patient. IV hydration, if the patient is not in a condition to take orally, then we might need IV hydration. But otherwise, oral hydration and maintaining the hydration status will be good enough. So as a direct correlate of that, severe painful episode, we might have to do IV hydration at least for the initial period. And when the patient is in a situation to take orally, then we can shift to oral hydration.
Exactly. So oral hydration will prefer. But if you have to give IV hydration, what fluid you would prefer, like or hypotonic?
Actually, what we do is giving maintenance fluid is half strength normal saline as a bolus dose, and then we again assess, and if there is a requirement for fluid, then we give. Rather than isotonic, other sirs, Dr. Day and Dr. Datta will be able to say, but what we usually do is giving half strength.
Finish. Dr. Rajiti, you
I give normal saline.
Okay. And for every patient, you give oral?
See, if the symptom is severe enough to come to hospital and patient gets admitted in a crisis, then I prefer giving IV fluid, because you need to consider our perspective. If our patients, if they have a small pain, they usually don't come to hospital. So if a patient comes to hospital, then that means the pain is severe, and in those cases I prefer giving IV hydration, because we can't ensure the adequate oral hydration ever. Okay, none of our sister will look after, other the caregiver will look after how much food he is taking or he is taking. So if patient is admitted, I give IV.
So there is no specific guideline in heart lung stroke guideline. What they say is oral fluid is better than IV if patient is able to take. If you give IV, don't give isotonic or hypertonic in bolus. You can give it as a maintenance fluid, isotonic. And many a case, experts also prefer half NS, as madam was saying. So whatever we can give, we must not over-hydrate. And for shock, obviously we would give bolus. So my question to Dr. Datta, do you need transfusion for this patient, like patient come with severe painful episode?
No, in my practice, whichever cases I dealt with, I didn't actually go for transfusions unless the patient is having severe anemia.
Yes. And our patient was on hydroxyurea. Should we continue the hydroxyurea during hospitalization, or should we discontinue? My question, Rajiv Dey.
Continue hydroxyurea? No, I continue hydroxyurea. even while the patient is admitted.
Even if the patient is having anemia like hemoglobin of 6-7.
If hemoglobin of 6-7, then patient needs to be transfused.
Yes.
And the reason for transfusion is we need to reduce the sickle percentage.
Absolutely.
And it cross 10 gram percent. But if the sickle percentage is less than 30%, then the chances of this painful.
So learning point is even with anemia we can continue hydroxyurea if reticulocyte count is higher side. If reticulocyte is very low, we are suspecting some aplasia. In other case, like we should continue. Dr. Ghosh, are you with us? Dr. Tapas Ghosh, are you with us?
Hello, I am audible?
Yeah. Question to you is there any role of vitamin D supplement or bisphosphonate for long-term bone health for the sickle cell anemia patient?
There is but no.
This network is very unstable, I think.
We can't hear anything.
Hello? But,
Hello? Yes.
Continue.
Continue, please.
So chance of osteoporosis is actually our setup. We rarely see adult patients with sickle cell anemia.
The problem is with the microphone, I guess. Sometimes it's.
Hello, am I audible?
Yeah, you are.
Yes.
Anyway, so
ডক্টর ঘোষ ডাইরেক্টলি বলুন মাইক্রোফোনটাকে ডিসকানেক্ট করে আই থিংক ডাইরেক্টলি বলুন শুনতে পাবো আমরা
Nothing is audible. We have to move to next question.
No, anyway, I think about that, the previous question, about this, I don't think there are any guidelines, and vitamin D supplementation and bisphosphonates. Bisphosphonate is predominantly used when we are having, the pathophysiology here, is there any role of bisphosphonate here? I don't think so.
My question is, would you recommend a DEXA scan? If you do a DEXA scan, then recommendation might come.
There is no.
I don't think there is recommendation for DEXA scan in this condition.
Because many sickle cell anemia patients we have seen with osteopenias and osteoporosis, their bone health is very bad.
I think that would vary from patient to patient.
No recommendation.
There is no recommendation for all to go for DEXA scan.
Yeah.
And that is for due to defective influx, I think, bone influx.
Yeah, absolutely.
But so, in sickle cell as well as in thalassemia, it is better to do a DEXA scan because many the patients present with osteoporosis and osteopenia. In my institute, a trial has just started on bisphosphonates in hemoglobinopathies, both in sickle cell and thalassemia. And it's really, but the dose is very less. The dose is very less. Its dose is like osteoporosis is once in every 4 months, rather than once a month. Bisphosphonate dose which we prescribe for multiple myeloma or any cancer patients with bone metastasis. The dose is less, but it is usually done by many groups.
Yeah, my personal opinion is also like that. I usually do vitamin D and DEXA scan. And if DEXA scans from osteoporosis bisphosphonate, I advise.
So why is it that the patients go for osteopenia?
It's like due to bone infraction, mainly.
Bone infraction, okay.
Number 2, one is bone infraction, and the thing is usually sickle cell and thalassemia. These patients, there is a hypermetabolic condition. So there is reactive hyperplasia of hematopoiesis. Okay, so there is cortical destruction also because of increased volume of the marrow, bone marrow. So that also causes osteoporosis. And the disuse atrophy because of pain, they don't use their limb properly.
Okay. My question is, Professor Madhumita, how do you immunize your sickle cell anemia child?
Thank you. You have raised a very relevant and important question. Immunization as such is important in all children. And there is no, these children should get all the vaccines under the national schedule. Plus, as we know, that these children may have functional asthenia and they are predisposed to infections by organisms like meningococcus, pneumococcus and capsulated organisms. So pneumococcal and Hemophilus influenzae vaccines against these two are there in the national schedule. So we have to ensure that they are fully vaccinated against these. In addition to that, vaccine against meningococcus and also typhoid. So we have to ensure that the sickle cell disease children are vaccinated against these also, in addition to the normal vaccines which are there in the schedule for all children.
Yes, and we should also repeat meningococcal and pneumococcal vaccine every 5 years. For adult patients.
Actually,
yes,
in the academy of pediatrics,
for pediatric,
recommends to repeat meningococcal vaccine for every 5 years, but till now, as of this day, pneumococcal vaccine, it's saying that after 2 doses, 1 dose and after finishing rule and one vaccine after 5 years, there is no need to repeat it again. And one more thing about Hemophilus influenzae vaccine against Hemophilus influenzae, normally in children, it's not given after 5 years. So if due to any reason, if it is missed within 5 years, it's not given anymore. But it is recommended in children with sickle cell disease that we have to consider giving vaccine against Hemophilus influenzae if it is missed before that.
Yes, even with adult patient, we give 1 dose of a vaccine.
I have
yes.
Query. Whether pneumococcal vaccine is part of national immunization program now, I don't know. I just want to know.
No, not in all states, but it is being gradually being introduced in states. Around 4 or 5 states, Delhi and all, they are giving pneumococcal vaccine, pentavalent. No, not in our state. It's not there in our state.
And do you keep both PCV and PPSV
included?
Ma'am, do you keep both the vaccine like PCV and PPSV 23? Both the vaccine?
Yes, actually, there are many advantages with PCV conjugate vaccines. Unless it is conjugated with a protein, that antigen will not act below 2 years of age. So PCV can be given below 2 years, and that PPV23 cannot be given before 2 years of age. And now the recommendation is that PPV23 should not be given as a standalone vaccine. If it is it has to be combined with either PCV10 or 13 or 7 or whatever. So
what we usually do, we give PCV13 and after 2 months of that we give PPSV23.
That is the recommendation. It is just alone as a solitary vaccine, PPV23 is no longer recommended.
And due to functional asthenia, we repeat every 5 years. My question to Dr. Rajiv Dey is that if you have a patient of sickle beta thalassemia who doesn't have any functional asthenia, his spleen is palpable, still would you consider this immunization?
I usually give. I really prefer to give.
Okay, I also give, but I'm not sure.
I'm very liberal about vaccination. So all my vaccinations, so I prefer to give vaccination.
My second case, 40-year male, this is an adult case of sickle beta thalassemia, 1 painful episode per year, no hospital 5 years, on hydroxyurea 1 gram per day, now admitted with pain in head, chest and extremity. He is admitted in my hospital now. It is his HPLC, hemoglobin is 80%, hemoglobin is 7, MCV 103, other counts are near normal.
Can you please go back to the HPLC?
Yeah.
HPLC. Okay, HBF. Okay, fine.
Unconjugate is there. A patient when admitted treated with tramadol and hydration and paracetamol with significant pain relief, but on day 3 of hospitalization his pain symptom worsened. SOP started, saturation fall to 82%, he was put on oxygen, with oxygen his saturation 94-95%. Now yesterday his saturation fell to PaO2 fell to 52% with 2 liter of oxygen, and today morning his PaO2 is 32%. This is his CT scan, bilateral mild diffusion and some active changes or mild, some patches bilaterally basal region. He was started on 5% tazobactam, azithromycin and morphine started IV 2 gram every 4 hourly. Now I thought of acute chest syndrome. I put DD of pulmonary embolism and pneumonia. So how would you manage this case? My question is Dr. Datta.
I think in this case you had already started the basic supportive therapy, hydration and oxygen, but along with that we should go for a blood transfusion in this case. This will along with all the tramadol, oxytherapy and hydration.
Yeah,
and also broad spectrum antibiotics here.
Yeah, we already started. So we given 2 units of transfusion. So even after that saturation, today morning PaO2 was 32% with saturation of 96%. So SpO2 and PaO2 is not matching. PaO2 is steadily declining. So my question is, Dr. Rajiv, would you consider exchange transfusion for this patient or only simple transfusion?
Before that, won't we go for a CT angiography to look for any pulmonary embolism here?
Yeah, I haven't done that. I was taught because it was in my DD that when patient is showing the typical other symptom like patient admitted with brain crisis, and typically the CT scan is showing some patches newly developed lesion that might be part of infective process which initiated this painful crisis, but obviously we can do a CTPA.
Yeah, because age is 7 years, no?
40 years.
40 years, sorry, 40 years. Yeah, 40 years is sickle homozygous, chest discomfort, dyspnea, saturation low. So our fast DD will be acute, that is
acute chest syndrome.
Yeah, acute chest syndrome. And when you have done all basic things, hydration and oxygenation, antibiotics, as well as blood transfusion. So everything is done, but in spite of that, if it is persisting, supportive therapy, usually there is no specific treatment for acute chest syndrome except supportive therapy. And in this condition, we may consider this thing, there is exchange transfusion, because that can reduce some amount of HbF. But once acute chest syndrome settle in, takes the upper hand, and not the specific HbF percentage. So in particular acute chest, often sometimes we use exchange transfusion, especially in the pediatric patients, but I think the supportive treatment is sufficient for management of acute chest.
Yeah. For this patient, today I have done an automated exchange transfusion. We exchange like 1800 ml of blood. Let's see what happened tomorrow.
Yes,
we don't know. Now for this patient, how to optimize analgesia, like 2 milligram of morphine every 4 hours. Still he is complaining of severe pain. In head he is complaining 9/10 and in extremity 6/10 with 2 milligram every 2 hours. So how do you optimize analgesia for this patient? Like what else?
You need to basically, it's very difficult to optimize. You need to give more morphine and along with tramadol So, and in these cases, often this tricyclic antidepressant, they also have some role. So we can give amitriptyline along with that. So,
do you ever give infusion of morphine, continuous infusion of ketamine for these patients? I actually don't have any experience with ketamine.
I haven't given ever. So, but it can be given.
Okay. My question to Dr. Datta, is there any role of thromboprophylaxis for this patient?
Thromboprophylaxis may be considered in this patient because of according to the clinical scenario, yes, thromboprophylaxis can be definitely considered in this patient.
Okay. Now, what would be the long-term treatment plan if this patient stabilizes? My question to Madam, if acute chest syndrome, kid of yours, after getting stabilization, what would you plan long-term? Would you put him on hemotransfusion?
This is a 40-year-old man.
No, consider it as a child with acute chest syndrome.
Yes,
what would you do?
Long-term management, of course, will depend on the symptoms. The symptoms and what is the baseline hemoglobin is maintaining, what is the frequency and the severity of complications or the episodes is having. The long-term management will and all situations should be given on the level of sickle HBS in this time to plan a long-term management. So if I would consider, depending on the symptoms, the frequency and the severity of symptoms, I would consider starting hydroxyurea to reduce episodes of pain.
He is on hydroxyurea 1 gram per day.
Okay.
And with that he developed ACS. So possibly we can start
there are situations where we have to plan for chronic transfusion based on the symptoms and hemoglobin. And I think Dr. Day will be more.
Yeah, so what are the conditions we do chronic transfusion in sickle cell disease?
Causes history of recurrent painful crisis. Another is history of silent stroke syndrome, silent strokes. So if these are there, we need to keep the hemoglobin around 10. We need to reduce the sickle HBS percentage less than 30%. But the thing is, along with that, we need to ensure that the patient are put on optimum hydroxyurea therapy. And that is, as Dr. Jina said, that low dose hydroxyurea is sufficient, but in these cases, but then we need to optimize hydroxyurea dose up to maximum tolerated dose, that is 35 milligrams.
One question to Dr. Day. What we usually face hydroxyurea for small children, the dose which is the tablet which is available is 500 milligram.
Nobody knows.
15 milligram.
We even give one tablet, one capsule once a week.
Everything method.
What we need is giving alternate day. So I don't know that is permissible or not, but we didn't have any other.
We don't have liquid formulation, ma'am, so we have to bear with that.
What I ask my patients is to remove the capsules and divide it into two and then take one part.
Will that work, like that granule inside the capsule?
I don't know, but I do that.
Okay.
We don't have options, no?
Yeah.
We don't have any other
A very small kid, I used to give hydroxyurea 1 day or 2 day in week. So
as Madam was telling.
Yeah. So with that, I would conclude this session. It's a nice session, very good discussion we had. Once again, I would thank you, the Hemoglobinopathy and Hemophilia Control Society North Bengal, for giving us that opportunity.
Yeah, but Dr. Shwaikat, you just came from after specialist residency in transplant.
Yeah.
But have you done in transplant in sickle cell there?
No, in Tata they are not doing it, like they are doing only malignant, not any benign cases.
Because the outcome of transplant is very good, more than 90% success rate if we do in sickle cell.
For very limited patient, I think, like this patient of repeated acute chest syndrome or CNS effect. For only painful cases, possibly we have many other drugs like crizanlizumab and voxelotor today.
That is more right, I think. Let's see how it will work. Okay.
Are these drugs available?
Yeah.
Because are these drugs available?
Yeah, we
Crizanlizumab accelerator.
Crizanlizumab is now available. On compassionate ground. You need to write to Novartis so that they can give you. And there is a trial going on in NRS Medical College in pediatrics and population. I'm PI of one of the trials, so
okay.
On trial it is available and on compassionate ground it is available.
Okay, thank you.
Thank you. Thank you. And
Over to Dr. Nadim.
Thank you so much. Very nice, very well moderated and very nice and very healthy discussion. Lot of things to learn for everybody. But real high flow things, half of thing I don't understand. Being very frank and fair, you see. Right, so I would now request the coordinator, Dr. Bitut Goswami sir, to just share a few words and express his vote of thanks.
Yeah, before that, Dr. Nadim sir, after many years, so I met you also virtually. So
I am seeing you after 20 years, maybe.
Yeah, maybe.
Maybe more, for all you know. That was 1997 when I saw you last.
No, not 20 years. It is 2005. We last.
2005. Okay, fine. Your memory is better than mine, huh? All right. So it's long time. It's so nice meeting you back. I mean, great. You're looking like a Vidwan.
Oh, sir.
Anyway, I'll get in touch with you. Let's get over this, sir. Please.
Okay.
You are muted, sir. Please, Dr. Goswami, you're muted. Please unmute your mic, sir. Please.
Yeah.
Sir, unmute kore nin, Bidut sir.
Sir, mic ta unmute karo.
Please unmute.
Acha. I will
Yeah, please go ahead from the beginning.
To open that video so that we can, that camera, so that we can see you. All of us, we can see you. This is very vital. Professor
See me?
Nadim, please. Yes.
Oh, I am in the.
You are game maker.
We can see
no.
Please,
That's a big honor. Thank you so much.
Without your, okay. So we have come to the end of our this world observance of World Sickle Cell Day, and at the end I would like to thank all our patron. I've already mentioned Professor Sushrutanagar, Professor Sanjay Mollik, MSDP, and Dr. Sandeep Sengupta, Dean of Students Affairs. I will thank Professor Ravindra Kumar Jaina for his marvelous presentation. Dr. Rajiv De, lot of expectation from your end, not only in the lecture. Thank you, Amidaji, thank you so much. Not only from your marvelous speech, but we also get something else from you. So, two Dr. Indranil has categorized that one is having A, another is having U. Okay.
No, sir, that's wrong. Both are having A.
Both are having A. We don't, none of us having U.
Anyway.
Maybe it's a printing mistake then.
Madhumita ma'am, thank you very much for your nice presentation. Dr. Taposh Kumar Ghosh, my favorite Vishwajit Hallar, Kullan Khan and Latruburti. Our devoted audience, and last but not the least, Dr. Shaykh M. Nadim, MD, PGI, MER, and his renowned Institute Nilam Pathology Lectures, with his team, without whom today's encouraging webinar would have been not possible at all. So, lot of thanks to Dr. Nadim. Thank you very much, Dr. Nadim. Thank you. We want to see you. Please, photo. Please,
The smartest pathologist of Kolkata and the most handsome
Oh,
pathologist.
come on.
Yes.
I am humbled by all those words. Let me, Amitadi is here and Andronin is here. My system of projection does not have a camera. The fact of the matter is I am in the background. I don't come in the foreground. I just stay on the background and let the players play.
So truly pathologist, you mean to say you are a truly pathologist, always behind the camera.
Yeah, well said.
So you won't be able to see me on this system. I have to shift myself to the next system to show you my face, but definitely will show you my face someday. Right now, let's hear each other.
So,
Wonderful, discussion.
My most one senior fellow I am getting, I just want to hear something from Amitadi at the end, please.
Didi, please, unmute করে একটু বলুন। Unmute করে নিন। দিদি আপনার মাইকটা আনমিউট করুন, মাইকটা আনমিউট করুন।
ম্যাডাম মাইক আনমিউট করুন ম্যাডাম।
হ্যাঁ এবার বলুন।
প্রথমত হচ্ছে যে this was a very nice and informative and really mind blowing session এবং আমার তো সবসময় আমি তো রিফ্লেক্টেড গ্লোরিতে ভুগি একটু ফর দ্য নর্থ বেঙ্গল মেডিকেল কলেজ, যে যখনই দেখেছি সব এত নর্থ বেঙ্গল মেডিকেল কলেজ থেকে এত কিছু হচ্ছে তখনই আমার সেটা ভালো লাগে। প্রথম থেকে শেষ অবধি শুনেছি, সবই খুবই ভালো লেগেছে। কিছু যদিও আমার মাথার উপর দিয়ে চলে গেছে ট্রিটমেন্টের ভাগটা হয়তো, তবু সত্যি বলছি খুব ভালো লেগেছে। 3 ঘন্টা কোথা দিয়ে কেটে গেল বোঝা গেল না, এটাই হলো সব থেকে বড় কথা। আর ওখানে থাকতে থ্যালাসেমিয়া কন্ট্রোল ইউনিট তখন নাম ছিল, প্রথম যখন শুরু হলো বিদ্যুতের চিরকালই এই ব্যাপারে উৎসাহ, ও চিরকালই এই নিয়েই কাজ করেছে, ওর উৎসাহ দেখিয়েছে এবং এখনো করে যাচ্ছে, লেগে আছে এটার পিছনে। তো মনে পড়ছিল আমারও ওখানে যে কদিন ছিলাম সেই কদিনের থাকার কথা, থ্যালাসেমিয়া ডে আমরা যে পালন করতাম বা সমস্ত সেগুলো মনে পড়ছে, and I miss all those golden days. Thank you all, very nice.
ইন্দ্রনীল একটু ভার্চুয়ালি দেখাও কে কে রয়েছে, বাকি সবাই একটু দেখাও না মুখটা। ইন্দ্রনীল, বিশ্বজিৎ কই?
তো দেখা যাচ্ছে।
নদীম স্যার, নদীম স্যার,
নাদিম স্যার তো বলেই দিয়েছেন উনি
can we take a group picture?
Yes, আমি সেটাই বলছিলাম। আর কে রয়েছে?
Everybody come on the screen. I can only see 1, 2, 3 is on the screen. Is there any more?
I think participants will be there. I think
no,
at first you take the no. At first you take the picture of the participants. Yes.
No.
At first you take the picture of the participants.
I think most of them.
Yes, take the picture of the participants first.
Okay, I'll take the picture of the participants as madam is ordering.
Yes.
No issues.
সৈকতকে পাচ্ছি না কেন? সৈকত, দুই সৈকত আছে।
কোন সৈকত? একজন আছে।
Hematologist.
He has left. No, I have seen that he has left.
অনেকে লেফট করে গেছে,
চলে গেল কেন?
সবাই নেই তো এখন।
Now you
যারা
can.
আছি everybody, সবাই ভিডিও অন করে দাও, যারা আছি we can take a picture.
Now I can join.
ইন্দ্রনীল তুই আবার বেরিয়ে চলে গেলি কেন? তোকে দেখতে পাচ্ছি না। আরে দূর।
Yeah, we have taken a click. No issues.
আসলে ইন্দ্রনীল ওই কালো চকলেট দেখাতে চাইছে।
না আমি আছি তো,
কোথায় তুই আছিস? দেখতে পাচ্ছি না।
দেখা যাচ্ছে তো।
আমায় দেখতে পাবেন কেন?
আরে আমি বলছি, সিরিয়াসলি বলছি কথাটা। হ্যাঁ, এখন দেখবি।
Good night. Okay.
Good night. Thank you.
Very nice.
Thank you so much.
Very nice reuniting with you, Rajiv. Seeing you after a very long time.
Thank you so much.
I keep hearing about you that you're doing wonderful, excellent. So nice to hear that. Great job.
আমি আজ ভালো করে বুঝতে পারবো।
রাজীবকে দেখে আমার অন্য আরেকজনের চেহারাটা মনে পড়ে, সিঙ্গার অনুপমের কথা।
হ্যাঁ
অনুপম রায়
সত্যি
না?
আস্তে আস্তে কিন্তু ওরকম দেখতে হয়ে যাচ্ছে রাজিদা
একদম ওরম লাগে ওকে দেখতে।
না এবং এবং মানে এটা হচ্ছে অনুপম রায়ের থেকে গানে কিন্তু রাজীবদা কোনো অংশে কম নয় এবং
তাই একদিন
ইনফ্যাক্ট
শুনতে
আমাদের
হবে।
অনেক হ্যাঁ হ্যাঁ মানে আমাদের
छिपके छिपके क्या हो रहा है भाई
এখনো আমাদের মনে আছে রাজীবদা সেই প্রিয়া ক্যাফে
অপশন রেখে দিয়েছি, হিমাটলয়েডের পেশেন্ট না হলে ওটা করবো।
Right. Thank you, Dr. Bittu Goswami, for
Thank you,
giving
thank
us
you.
Bali.
Thank you all.
thank you so much
Thank you so much. Take care. Bye-bye. Good night.
thank you Nadim, thank you everyone.
Thanks. Bye.
Regards to all.